Okay, good morning. Welcome to our third Endometriosis Patient Day of 2022. I'm Dr. Tracy Haas, a family physician and Endo Found board member. As you probably know by now, March is Endometriosis Awareness Month, and this is Endo Found's 13th year of hosting this conference, geared for both patients and the medical community. It is our sincere wish that women around the world are diagnosed with endometriosis earlier, faster, and offer definitive treatment for endometriosis sooner. 2 weeks ago, Dr. Carly Goldstein walked us through the impact endometriosis has on fertility. Last Sunday, we got the opportunity to hear from experts about peritoneal endometriosis and the complex pain mechanisms that involve peritoneal disease. Today, Dr. Rich will lead a discussion of deep and debilitating endo, from endometriosis that infiltrates bowel, deep structures such as the urinary tract and the thoracic cavity. And I just want to thank you for being here. Please know that if you're a patient or someone who supports a person suffering with endometriosis, that you are not alone. There is hope, and the Endometriosis Foundation of America is here to continue in the fight for research funding, patient advocacy, improved access to care, and education on all levels. I hope you find the conference informative and hopeful. Please join us and spread the word and about our medical conference that will take place next Sunday on March 27th. And now it is my pleasure to introduce you to a world-renowned endometriosis surgeon, a pioneer in laparoscopic gynecology. He's performed more than 4,000 laparoscopic procedures and is a senior advisor to the Endometriosis Foundation. I'd like to introduce you to Dr. Harry Rich.
Thank you very much. Thank you very much, Tracy. It's sort of interesting trying to do this in 4 weeks, like with 1 day Sundays for a whole week, instead of us all being together in one room and being able to express ourselves that way. I'd like to say a few things about endometriosis in general, and especially the topic of what we're talking about, deep disease. First of all, a few words of nomenclature. I like to use the word deep fibrotic endometriosis. I don't find there's ever been any evidence that endometriosis infiltrates tissue, and people use the term DIE, deep infiltrating endometriosis. And I don't believe it's die, I believe it's cure. And I'd like to emphasize to many of you, because the last talk of the morning, someone said that endometriosis is impossible to cure. I don't believe that. I believe that if you excise it all, it's gone. I believe endometriosis comes down from during embryological development, and it usually finds itself in the deepest, most dependent part of the pelvis, which is a cul-de-sac. So endometriosis means rectal and vaginal deep endometriosis in most cases. Now, I'd like to say, well, I've been doing this for many years. I started in '76, and I was very fortunate. I came back to the same town where my mother and father were doctors, and I had a lot of material. In fact, I came back to a town which did not do tubal ligations, or any type of infertility laparoscopy. So within 5 years, I had done close to 1,000 laparoscopic operations. So I was lucky. So I saw the evolution of endometriosis for myself, excising the disease in 1978 to excising endometrioma cysts inside the ovary in 1979-80, to progressing to doing deep dissection of the cul-de-sac after 1985. And that included the first rectal resection and some of these other type procedures that you'll see in much more depth today as we go on. Interestingly, my topic is the times they are changing. And I find many gynecologists today, pelvic examination is almost an afterthought. Right now I'm retired, and I was at our local swimming hole the other day, and I met a woman who was a family doctor, and we talked a little bit about examination, especially pelvic exam. And it was her impression that as a family doctor, they did what was called the rectovaginal exam. Well, when I presented the idea to American College of OBGYN about rectovaginal exam, I was pretty well discouraged from them adapting that as a routine examination in women who had pelvic pain. Now, let me emphasize that they were doing rectovaginal exams to be able to test the bowel for any occult bleeding too. Well, for me, a rectovaginal exam was very, very important to be able to tent up the cervix and feel the uterosacral ligaments. So to me, almost all endometriosis can be diagnosed by rectovaginal exam, not by MRI or CAT scan. So the concept that you have to see it, well, I'm not so sure. I think you could see it with a rectovaginal. You could note that it's there with a rectovaginal exam. Another thing I want to comment on is you'll hear about all these different colors of endometriosis. Now, endometriosis is endometriosis glands and stroma surrounded by fibromuscular tissue. If there's no fibrosis, it's not a problem. It's a fibrosis that comes in the color white. So all endometriosis that causes pain or discomfort will have some white inflammatory reactions surrounding it. I do believe that if you follow the white fibrosis around the endometriosis lesion, in almost every case, you can excise it fairly completely. Now, I'd like to emphasize present treatment that we have today with a robot. I believe that with a robot, a single surgeon does the surgery, sees very well, but on the other hand, they don't feel the crunch of the tissue when you are near endometriosis. With endometriosis differentiating from normal tissue, the endometriosis always, if you operate next to it, the fibrosis reaction of it will cause crunching, a crunching feeling with the scissors, so you know you're in the right place. Unlike some of the surgery that is done way away from the tissue, like on the rectum. Instead of following the mass and staying with the tissue, you could end up with a lot more tissue removed than is indicated. Anyway, we have a busy day today. We have lots of great guest speakers today, and I'd like to get the morning started with Victor Gomel, who's the professor. I met him in 1978 when he did a course in New Jersey, but he was a father of microsurgery. He's been honored throughout the United States and, of course, in France, where he's, I'm not sure if it's a Legion d'Honneur, but it's a very famous award that he's gotten there. But he's been well known throughout the world and has written multiple textbooks on both laparoscopy and microsurgery. So, Victor, could you talk to us today about everything that you've been doing, especially the microsurgery for endometriosis?
Do you want me to do my presentation?
Please, Victor.
Talk.
Presentation and talk. We need you to talk both, to talk and present.
Okay. So I can talk. Look, you know, I started by very early, and in 1969, I went to, or 68, I went to Palmer to learn laparoscopy. And then I started on 1970, I started with microsurgery and with also operative laparoscopy, because I was very lucky I had to buy all my instruments. I was young and didn't have much money, and the department didn't have much money, and nobody in the department, was progressive. They thought I was crazy, and people would open the door when I was doing a laparoscopy and mock me. But I was very lucky because I saw that I didn't have I bought all the instruments, but the insufflator was quite expensive. And we made the insufflator, but to make the insufflator, I had to get permission from the head of anesthesia. And when I went to see him, he kept asking me, what is this laparoscopy, how you do it, what is the CO2, and so on. And then when I booked the first one, I see the head of anesthesia who never gave an anesthetic in gynecology. He always was in the surgery. He was giving anesthesia in my patient. I said, I wonder why. Is he going to look what I'm doing? The second case, the same thing. I went to the head nurse. She says, don't you see he keeps taking blood every few minutes from the patient? He's trying to do a research himself and looking at the blood PCO2 at different positions and so on. So I was so bloody lucky to have a man like him who saw what I was doing, and I could show them everything. And in those days, it wasn't like now, where you have beautiful ways and things to look with. We saw the things with our eyes, one eye on the laparoscope, and everybody had as sterile an eye as everybody else. So that's how we showed people what to do. And when we wanted to use 2 hands, we had to get somebody, I used to call them slaves, to hold the laparoscope where we wanted it without moving it. So those were the days. Hello?
I'm with you. I'm with you, Victor.
Okay, carry on. So if you want my text, I have to arrange it to see it. Can you see me?
We see you well.
We see you well, but I have to find my text. So you talk a little more, and then I will
share screen
to talk.
The share screen button.
Yeah, I will do. But you talk a little. Let me arrange my stuff here.
It's good for me to hear somebody using their eye for laparoscopy, because the first 10 years that I did laparoscopy, I burned out my right eye, I think. In my next 20 years, I burned out my left eye.
Look, look, we didn't have any other, look, it's until 1980 that somebody,
86, they came up with video.
No. Before video, I think they had in 1980, they brought one of the companies, I think they came to me, and I was able to buy at a good price something.
You had probably
for the department. I was head then. Since 78, I became head. They forced me to be head of department. So I have to find my things.
Shall I do my bit while Victor looks for his?
Yeah, you do your bit and then I do my bit.
Yeah, let me introduce to the people here, Ray Gary. Ray Gary came over to see what I was doing back around 1990, 91, and we wrote a book together on laparoscopic hysterectomy. So, and we've been friends for forever since then anyway. So I hope to get over to England to see you again in the near future. So carry on, Ray. Ray was the leader in Great Britain for many years. And now he's going to tell us a little bit about.
Okay, well, good morning from an unusually sunny March day in England. We do see the sun occasionally. I was thrilled and honored to be invited to join the faculty of this meeting. I was slightly less thrilled when Tamir's invitation suggested I was the only person available to talk about endometriotic surgery for dummies. I wasn't sure whether it was the audience or me that was the dummy, or perhaps both of us. Anyway, from one dummy to another, here goes. I'm essentially a data man, and I try to validate what we do. And by and large, I believe that one of the things that marks out each of us individual is who we've met in the past. And I want to mention two people who've had profound influence on me. And this guy is the first one. He's now grandiosely Syrian Chalmers, but when I knew him, we were both very junior doctors working together. And I was learning my trade, just how to do various techniques and procedures and just how to become an obstetrician gynecologist. But he, even at the earliest stages, was a guy who was very aware of the fact that medicine was often wrong. Doctors, whisper who dared, sometimes made mistakes. And he felt it was very important for any new technique or therapy to be properly evaluated. And he went on from these ideas to eventually become the director, or the first director, and basically the man driving force behind the Cochrane collaboration, which is, for those of you who don't know, an international body that collects and collates research data, particularly randomized trials, puts them all together and elaborates them. So it's all about data. But as he said, doctors may get things wrong. And this started really way back here. Hippocrates, the most revered, the father of all medicine, he was a Greek philosopher, of course, and doctor, and he espoused a theory which probably killed thousands, if not hundreds of thousands of people, because he believed that disease, the body was made up of 4 different humors, and disease was occurred when these humors were out of balance. So the treatment for disease, even diseases such as menorrhagia, heavy periods, was a bloodletting. So many, many people were damaged by this erroneous concept, but it was an erroneous concept from somebody who was so intellectually giant that nobody saw fit to challenge this. And the theory lasted for 2,000 years. So anybody, anywhere, can be wrong. So I was very lucky, like the other guys. I started to do endometriosis surgery and all sorts of endoscopic surgery at the time it was taking off. So I had loads of opportunities to measure and evaluate these techniques. I finished up writing about 180 papers. I did 9 major randomized trials and collaborated in 4 Cochrane reviews. So I did quite a lot of trying to evaluate stuff. The biggest study I did was on hysterectomy, the Evaluate Hysterectomy trial, where we compared women who'd had abdominal hysterectomy, vaginal hysterectomy, and laparoscopic hysterectomy. And these were some of the brightest guys in the UK organizing this trial. And we did show very conclusively that it was a good idea to avoid an abdominal incision, and that without an abdominal incision, people got better quicker, they had less pain, they returned to normal activities, and generally it was a good outcome. Unfortunately, I learned something else very quickly in the business of doing trials, is that it's quite often a business to shoot the messenger, because as well as showing all these benefits of laparoscopy, we also demonstrated a small but significant increase in surgical complications in these early days of laparoscopic hysterectomy. So I found my invitations to speak about hysterectomies very quickly dried up after this study was performed. Anyway, I was a shot messenger there. Anyway, the other guy who obviously influenced me very profoundly was, of course, this guy who needs no introduction. You can see him here in surgery with this intense concentration, which was such a feature of his work. But what you might not be aware of so much, this is Harry at an anatomy lab that I ran up in Perth in Australia when we were there. And these are 3 British young gynecologists, and look at the expression on their face. Rapt attention would be one, almost you could say awe at listening to the great man speak. And that is certainly the effect he had. Anyway, as Harry already alluded to, we wrote a book together. And this gave me the opportunity to spend a couple of weeks with Harry and his lovely wife, Liz, and family while we were doing this. And it gave me the opportunity to watch a lot of Harry's surgery. And obviously, doing this book, I was really interested in watching him do the operation he described, laparoscopic hysterectomy. And that was great. But I also had some fairly boring hours watching him do another operation which he devised, which was called the foreveroscopy. And these were his operations on advanced pelvic, what he likes to call deep fibrotic endometriosis. And I was surprised because I considered myself an expert in endometriosis surgery, because I had 2 very nice lasers, and we used to laser away happily at our little red spots and brown spots and things. And when we came across the fibrotic material, we used to use words like it's old or it's burnt out, and therefore didn't need treatment. And we used to leave it because it's technically too difficult. When I watched Harry do one of these very long operations, and I said to him, Harry, you're wasting your time. Why are you doing all this? And he said very little. He said, go and to the Path Lab the following day and look at the specimens. And I recall it very clearly. There were 19 little pots, all of which had some endometriosis, active endometriosis inside these fibrotic. So my vision, my conversion was absolute. I realized that what I was doing was entirely wrong. And this was really painful in every way, because it meant learning to do much more difficult and much more challenging surgery. Anyway, being what I am, I then also tried to follow the outcomes and did an early study. Then we followed up quite a lot of people for 2 to 5 years. And then I did a randomized trial. This was a placebo-controlled crossover trial for those of you interested in the techniques. And I regard this as way the best randomized trial we did. I'm not sure how many of you in the audience would volunteer to take part in this sort of surgery. But anyway, what patients had to do was volunteer to undergo 2 surgeries 6 months apart. And we would fill in a whole gamut of questionnaires and measurements at 0, 6 months, and 12 months. And the half of the group would be randomized to have just an initial diagnostic procedure, followed 6 months later by definitive excision. And the other group would have their primary surgery immediately, followed 6 months later by a second look laparoscopy and further treatment if any more was required. Now, the first group allows us to see the effect of a placebo because we had 2 different things separated by 6 months when essentially nothing had happened. So we could measure what patient's response was compared with the other group where we could compare the effect of the definitive surgery. Now, the important thing about randomized trials is that it's essential that the patient doesn't know what was going on. In fact, it's essential that everybody doesn't know what's going on. And so we went to great lengths, absurd lengths almost. We kept the operation notes in the theatre filed away and just sent a simple, nebulous summary down. Nobody caring for the patient knew what procedure they'd had done. We put the same number of incisions twice. We even put a drain in and put some fluid in, so there was a bit of drainage, whether they'd had a major procedure or not. The patients allowed to give their own anesthetic, analgesia. They had patient-controlled little buttons they pressed, and within safety limits, they could give what they needed. And most importantly of all, they could discharge themselves when they felt ready. And this led to some things illustrating how hard it is to do trials, because people are so different, individuals are so different. But we did have a couple of women who had no major surgery, but stayed in hospital for several days and had an awful lot of analgesia and made heavy weather of it, while we had, more worryingly, more women who had major surgery, sometimes lasting hours, who didn't think they needed any analgesia and took themselves home after a very short time. So this was an interesting and warning thing of how difficult it is to compress individuals into a group. Okay, so what did we find? Well, the simple headlines were that it was all good. The laparoscopic excision improved all aspects of pain. Actually, that's not true. It was 3 aspects of pain: menstrual pain, non-menstrual pain, and dyspareunia improved. There was no significant difference in dyschezia, pain with bowel movements. Okay, but basically everybody was improved. And similarly, we had several validated quality of life assessments, and they also improved dramatically. And there was also a significant improvement in sexual activity, with several women who had pareunia and was not sexually active becoming sexually active. So in conclusion on this little study, what we were able to say that in the placebo group, if you like, in the people in the 6 months between the first laparoscopy and the second one, the disease had got worse in 45% of cases. It had stayed the same in 33% of the cases, and it appeared to have got better in 22% of the stages. And I wonder quite a bit about Harry's certainty that once everything's excised, it's excised. So I'm not sure we know quite whether it's just inadequate surgery when things come back, or whether in fact some of them can actually recur and regrow. In the immediate surgery group, when we looked at 6 months after their surgery, only 56% of our patients had no evidence of residual disease. So we failed to get rid of all the disease in nearly 50% of the patients. 43% had, mostly they were just tiny little bits, but some of it was quite severe disease. And in 6%, which is actually only one patient, it was worse. So overall, we'd say 88% had significantly improved. But looking at it, you know, it wasn't as good as we would have hoped, that nobody would have anything left. And I'm sure Harry, and he's probably right, that he's a far better surgeon than we are, and that it may partly be due to inadequate or too difficult a procedure, or a weighing that the extra surgery is worse than the extra benefit. But there is no doubt in our hands, we couldn't get rid of all the disease. And this placebo response, it was very odd. And it questions whether these quality of life surveys are good, are valid or not. Because not only did the people who had no surgery report improvement in their symptoms after 6 months, the people who had the definitive surgery first at 6 months said they had real improvement, but it wasn't very much better than the people who hadn't. And that group, the immediate surgery, after the second 6 months, they reported more improvement, even when they hadn't had additional work. So placebo response, assessing actually really what happened, is much more difficult than it sounds at first. And overall, we thought there was a placebo effect of about 30%. And if you go to the literature on all sorts of treatments for all sorts of conditions, this is about what's found. There's about a 30% placebo effect. Pregnancies. Our study wasn't powered enough to get to look at pregnancy, but there were 12 women trying for a pregnancy, and 6 of them conceived, all of them after excision, and 5 of them within the first 6 months. And as I mentioned before, 3 of the women were apolionic and became sexually active. Okay, so in conclusion, laparoscopic excision of advanced endometriosis, even in my unit's perhaps inadequate hands, is significantly more effective than placebo. And 80% of people report symptomatic improvement after surgery, but 20% of our patients didn't report a benefit. So, endometriosis surgery in dummies. Hopefully, this dummy has been able to help some other dummies to understand a little bit more about the benefits and the limitations of excision of endometriosis. As every Englishman does, we revert to Shakespeare, and the fool doth think he is wise, but the wise man knows himself to be a fool. So perhaps it's not too bad to be a dummy. And surgical excision has a definite role in the management of deep endometriosis. Thank you very much. Hello, is anybody there?
You're all
Thank you
here.
very much, Ray. That was very good.
Thank you.
And
if we can now, Victor, you want to say a little bit more?
Of course.
I thought so. Okay. Okay, can we switch to Victor?
So I have to share a screen with you guys.
You do. While you're working on that, let me just ask to Ray. you know, we did our study on 100 patients who had
second looks in 1985, 86, and it took another 5 years to get it published. I emphasize that because most of these things that had good results were very hard to get published. And when we finally got it published, well, the stats showed we had 30% at second look said no endometriosis. These are patients with stage 4 extensive disease. And that was before we had an aggressive feeling toward the rectum. So I would say that if we did that same study today, the results would be much, much higher.
I'm sure that's true. I'm sure everybody's got better, but it's still, what we have still left unsaid is, you know, your certainty that getting rid of it all once is all you need to do is, I'm not so sure. It might be right, it's probably right, but I'm not sure that it can't come back, or even the subclinical or stuff you can't see, that flare up at a later date. So the concept of actually being able to excise absolutely every single little potential piece of endometriosis is, I think, still not proven.
We admit that none of us have microscopic eyes, and certainly parts or areas can be missed. Now, on the other hand, areas that we excise, if we look carefully at those areas, most of the time it's be very rare to find any additional disease. Victor, I think we'll go with your presentation now. Thanks.
All right. Can you see?
Yeah.
Beautiful.
That's from my where I live. I took that. So from here to eternity is my friend Tamer Seçkin who said, because you know, we haven't done very much for many years on endometriosis, and we are still doing what we did 30 years ago. Look, for the people who are listening to that, I used a few things. You see, what I will do is I will make it. Okay, now we have the full text. Endometriosis is a difficult and enigmatic disease, a disease that affects only women directly. So, and her environment, partner, family, etc., indirectly, but significantly. Chronic pelvic pain, dysmenorrhea, dyspareunia, and as you can see, even depression. A disease that is diagnosed with increasing frequency and is the commonest cause of pelvic pain in women of reproductive age. Affects women of reproductive age. It is a polymorphic disease in appearance, in the variability of severity of symptoms. It is frequently progressive and invasive. Surgery remains the most effective treatment for endometriosis. For surgery to be effective, the use of a delicate microsurgical technique is mandatory. Microsurgical principles the microsurgical principles were developed over time with the use of a non-human animal experiments and clinical observations, which included systemic second-look laparoscopies performed 8 to 12 weeks after the initial surgery. Microsurgery has been erroneously defined as surgery under magnification. In fact, magnification is only one aspect of microsurgery, which embraces a broad concept of tissue care designed to minimize tissue injury, prevent postoperative adhesions, improve postoperative course and outcomes. Delicate handling of tissues, use of an atraumatic technique is mandatory. Judicious use of electrical and laser energy, irrigation with heparinized Ringer's lactate. We still use saline, which is toxic to the cells of the peritoneum. So meticulous pinpoint hemostasis, identification and use of cleavage planes, complete excision of abnormal tissues. You see, as Harry Reach said, excision and removal of broad adhesions, precise alignment and approximation of tissues, thorough lavage with Ringers at the end of the surgery. We instill 500 ml of Ringer solution with 500 milligram of hydrocortisone succinate before closure. Use a magnification and obviously use magnification as necessary. And after the surgery, we give 1 or 2 doses of dexamethasone. These are the principles. So any questions, any talks, I am prepared to talk. Are you there?
Yeah, yes, Victor. I remember we used to use Dexedrine and Phenergan for times 12 after all our surgeries. That was in Boston in the early 70s. So you still use dexamethasone?
Yeah, for dexamethasone after the surgery.
Right. Well, we enjoyed, or I like the fact that you use so much Ringer's lactate, and that was a great point to be brought home to everyone that
Ringer's lactate is reasonably caring for the cells, while normal saline is toxic to the cells of the peritoneal cavity.
Do you know that was known already in early 70s?
Yes.
And you couldn't change people. And then there were a lot of, which I have them, a lot of in the journals that shouldn't be used, toxic, that saline shouldn't be used. But I mean, when I see a lot of articles, even now, it's saline.
Yeah, it's very interesting that even these studies with the newer things, when they're comparing
various studies that Ethicon had using some substance that was supposed to help prevent adhesions, they're comparing it to normal saline, not Ringer's lactate. So of course it looked like the studies were positive for their products. Instead of comparing it, like I said, like you said, with Ringer's lactate.
Of course. And it's amazing. You know, when I started microsurgery, I started to decrease adhesions. You see, this started when I was a resident. They used to, you know, when I was a resident, there was a tremendous amount of sexual disease. And they used to do, obviously, laparotomies at the time. And they would go into, they would make an incision, and you would see that the abdomen was not, most of the time quite clean, no adhesions. And you enter the pelvis and you'd see adhesions there. So they would open the tube and put a plastic thing for the tube not to close, with 3 incisions. And then 2 or 3 months later, they would do another surgery to remove those implants. And I would see that there were adhesions in the abdomen and in the pelvis. And then I thought that, the reason is that the surgery was successful, not more than 25 or so percent, because of the adhesions. And that's what started me to search, what can we do to decrease adhesions? And what I did is I went to the literature starting in the 1890s. The stuff that was there was incredible.
Amazing.
The guy, it's amazing, especially in Germany and in France. There were papers that told you if you have blood in the peritoneal cavity and there is a damage in the serosa, it will, the blood will come and to the area that has been damaged and cause adhesions. Then all kinds of things like this. And I wrote this in an article quite recent that I was asked to do by Fertility and Sterility, and under the title of From Laparotomy to Laparoscopy to IVF.
Nice.
And in that article, I demonstrated all of these things from the past. And after I saw data that demonstrated if you have blood in the peritoneal cavity, it causes adhesions. But if the blood is what do you call that? You see, one word. What I use actually.
Sorry.
Retrograde debris?
No. What do you do what do you give if you have a clot of blood?
Anticoagulant.
Huh?
Anticoagulant.
No.
You suction it out.
Irrigate and suction.
No. There is a product that you give.
All right.
Okay, in our day or past tense?
Huh?
Okay.
Anyway.
Okay, let's get into the clinical nitty-gritty of this meeting.
And for that, I'd like to introduce the first case, which is about, the patients here, or the video of the patients here, Mrs. Karnak, And also, I'd like to say Tamir Seshkin is going to comment about this case. And let me introduce Dr. Seshkin. Dr. Seshkin is the man in New York. He was, we practiced together in around the turn of the century. That was 2000 for a few years. And we met for the first time
10 years before that in Hawaii, where I was giving a meeting, and I met him we were out for a jog one morning, and we've been fast friends ever since, sharing all kinds of experiences. So let's start with a video on from Ms. Karnak.
And then the next 2 weeks, I'd be great. I would feel no pain. I'd be happy. I'd be dancing. So I started thinking, well, gee, this is probably not my back. This is probably related to gynecology. So I went to my gynecologist, who ran a bunch of tests, uterine biopsy, sonograms, didn't see anything. Hi, everyone. My name is Lena Karnak, and I'm a patient of Dr. Sechkin. And, my story is probably very similar to many other women who come to Dr. Sechkin in pure despair after having been ignored for many, many years. For me, it started when I was in my early 40s, and it started with a simple backache, which was shooting into my left leg. I was in my early 40s. I was a bit chubby. I spent most of my working career sitting, and I thought it was, sciatica or a back problem. And so I went to see chiropractor, a physical therapist, and spent a few years doing Pilates and doing all kinds of things to my back up until the point when everyone said, well, you know what? It's not really your back. We don't see anything wrong with your back. At that point, I also realized that my very severe pain really only occurs for 2 weeks during the month. So from ovulation until the end of my period, I would be in horrible pain. And then the next 2 weeks, I'd be great. I would feel no pain. I'd be happy. I'd be dancing. So I started thinking, well, gee, this is probably not my back. This is probably related to gynecology. So I went to my gynecologist, who ran a bunch of tests, uterine biopsy, sonograms, didn't see anything. It was getting worse year after year. So I saw 3 very prominent physicians. You could probably recognize their names, big stars in big teaching hospitals. They were extraordinarily dismissive. Everyone used to tell me, well, no, it's not endo, because at that point I started doing my own research, and I would come with a big file and I would say, listen, this is what's happening to me. Can it be endometriosis? And they would say, no, it doesn't manifest itself this way. It does not manifest itself as a pain in the back and in the leg. And you have no pain in your pelvis or your abdomen. So stop practicing Google medicine. Stop searching your symptoms. Just stop. It's in your head. You need to lose weight. You're imagining it. You're old and fat. Get over it. It's not endometriosis. So I did that almost for 7 years. And then, how do you live with pain every 2 weeks out of each month? You take a lot of Advil and you carry on. I carried on. I had 2 kids. I had a busy job. I just decided, listen, I'm in my late 40s. Maybe it'll go away. I think it's endometriosis. No one is listening to me, but I'm not quite sure what to do with myself at this point. And then I had a routine physical, and I was sent for a very routine abdominal sonogram, and I saw the tech's face just kind of drop, and she had me talk to a doctor almost immediately. And I got a diagnosis of severe hydronephrosis, which I had no idea what that was. So I Googled it, my best friend Googled, and it was a complete kidney failure of my left kidney. And I went to see a urologist who said, I don't know what's causing it, but we should remove it. So I guess I don't know why it took me so many years. I think because there was so little written about endo. I mean, the little that I could find gave me the idea that it could be it. But since so many doctors kept on telling me, well, it's not, it's your back, it's your weight, it's your head. But I finally found myself an endometriosis doctor. And I remember the Google search. I said, best endometriosis doctor in New York City. And Dr. Sechkin's name came up. And I made an appointment. And it was February 2018. Like Dr. Goldstein, spent 2 hours listening to me, looking over my records. And I think prior to examining me, they said, yeah, it's endo. It sure sounds like endo, and your systems do exist. It's just it's not written up anywhere. It's rare. And they sent me through a few other doctors to check the urologist, the bowel specialist, the MRI, which finally did confirm that it was extraordinarily invasive endo. And in addition to basically taking over all my reproductive organs, it chewed up the ureter leading to the kidney and strangled the kidney. So on April, I think 25th, 2018, I was actually in a lot of pain. I was ovulating. I went in for my major surgery. I think it was like 9 hours long. And, all the reproductive organs came out, as did the left kidney. And it was a tough surgery. Every surgeon who was there told me afterwards that was a tough one. But when I woke up, I felt miserable, but I wasn't in endo pain anymore. And it's almost 4 years. My anniversary is coming up. And I have a lot of other aches and pains, but I have not felt endo pain since then. So I always say thank you for saving my life, for giving it back to me, for letting me enjoy my life again and feeling like a whole human being the entire 4 weeks of every month and every year. So thanks so much to the Sechkin endometriosis team. And please don't let anyone, if you're suffering with this horrible disease, call you, ignorant or fat, and do your own research and be your own advocate, because that's what I had to be in order to help myself. And I'm really doing well now. And I hope everyone who suffers from this horrible disease eventually does well. Thank you.
Tamir, you're on. Say a little bit about
Yes.
this case.
Do you see my screen?
Yes.
Yeah.
Do you see it? Thank you.
Yes.
This. Okay. Do you see it?
Yes.
Okay, 1 second. It's not. All right. I don't know if it's going to play the way I want it. Okay. All right. If you don't see this screen completely, I have to rearrange this screen again.
No, it's okay.
See? Okay, no problem. All right.
Yeah.
All right. Let's go here. Okay. There you go. Okay. All right. So thank you very much. First of all, thank you for all the participants, Harry, Victor, Ray, Dr. Haas. You made it happen. Today is the day for this is not 1 second. I have to pick another. Just one apologies. Okay. All right. Here you go. Okay, my apologies. Okay, so please accept my apologies. Thank you, Ray, for a beautiful presentation. I picked that endometriosis for dummy topic because In Britain, it may not be the same context it may be used, but this is a common joke subject here for all of us little dummies. For simple things that are not understood easy, we use that. And I think it's very over time to use that for endometriosis for us, as you said, for doctors and for patients.
We have a lot of dummies in this country.
Thank you. And thank you. And I did use your classic randomized study last weekend. That was the only reference that's credible to be found still, the prospective double-blind study on endometriosis surgery, excision surgery. And it's interesting when it is going to be ever repeated again for the things that are considered. Victor, you have been my mentor from medical school on. I've been following microsurgery. The principle hasn't changed, and thank you for being part of this. This is historical, in my opinion. Endometriosis surgery will never be of any quality if we don't do meticulous hemostasis, meticulous tissue handling. It's overall every lesion is like a pixel, a microcircuit that connects to the brain, and it has to be taken off. And thank you for Harry for many things that we did together. I have to say I have a conflict of interest. Obviously, I'm in private position, and I try to tell everyone when they tell their stories, it does not necessary to mention my name. I apologize, but Linda Karnak has to be held to her own feelings, and I appreciate her kind comments. I put this word extended hysterectomy with nephrectomy because endo is a disease outside the uterus, and uterus itself, almost 30% has pathologies in the presence of endometriosis, whether it's adenomyosis, fibroid, this. But endometriosis, in essence, is a disease outside the uterus, and if you don't clean it well, it will not, your definitive treatment, if it's hysterectomy, is not going to help. In this case, I use the word extended because I'm trying to bring attention different levels of difficult hysterectomies. All hysterectomies are not same. So I put this yellow and blue violet flowers because it's nice to remember what's happening in Ukraine. All our black and the gardeners are from Ukraine. We flowered our street with spring colors of Ukraine. Our heart goes for them. Linda Karnak's story hit Washington Post. Somehow, I don't know how, Linda is a very prominent Ivy graduate lawyer, very smart, and she was found to be dismissed. And this hit the big times, and this has been covered throughout the major newspapers and outlet. A kidney being also removed with hysterectomy, and she suffered this many, many years. In that sense, it's important patients speaking up and their power and the press recognizing them. That made our foundation very strong because there were people like Linda who went out and spoke. Nobody from the foundation alerted Washington Post. Somehow she was contacted by them or she contacted them. I still don't know the real story. This story was incredible. And there is a link there. You can really, oops. Are you seeing my screen?
Yes.
Okay, all right. Let's see, what am I?
But it's not, you are not, yeah, now it's okay.
All right, this is Linda's, what we found with her permission, I'm playing this, okay? So this is her uterus, a little fast forward. This is her left kidney is completely shut down. This is what you say, we're approaching, mobilizing the sigmoid, the tube is up there. So this is the ureter. We immediately see it. We have an ICG green in the retrogradely inserted. This is the IP ligament, non-visible, but ureter is ICG green mode. You can say how it is. So in this case, obviously, systematically, methodology is obviously to mobilize the sigmoid, and we tie the IP ligament. I typically do this so I don't have to go back. I don't rely on these ligatures and much. I tie my arteries and vessels generally. Then I can use my ligature, bisect it. So we're trying to approach where the real pathology is. I have a ICG green guidance. For us, it's not difficult to approach these lesions. Over the years, you develop that skill and experience. These natural spaces are discovered easily. Retroperitoneal you approach, continue to. So she has bladder implants. She has rectovaginal endometriosis. She has multi-organ, multi-compartment, deep fibrotic disease. I don't use the word invasive. I use infiltrative for organ, transmural organ. So this is what's happening. We are getting near to the uterine arteries, isolating them. However, the uterine arteries are basically main insertion to the uterus is totally obliterated. And you can see the ureter is kinked there. And we're preparing the posterior cul-de-sac in this case. I'm going to go a little bit forward. And similarly, we're approaching from the right parametrium in the same manner and preparing the cul-de-sac for complete total hysterectomy. We have to reach there. So here I have to make a decision, where do I tie the uterine arteries? In this case, I elect to tie the uterine arteries at the hypogastric artery level. So you see the obliterated umbilical ligament and hypogastric artery. So basically raise the hypogastric artery with a, in this case, I'm not doing, apparently I feel so confident, I guess. Tie the uterine artery right lateral to the, in front of the obliterated umbilical. So we move on after this. The whole lesion and total we like to remove. However, first I have to cut through the fibrotic mass now. So I have some degree of control of bleeding, and we bisect this. This is Harry's instrument. I basically adopted myself. It's an incredible instrument that you feel. You feel and you hear the crunch of fibrotic tissue. There are cases that the scissors break, endo tissue gets exactly like a bone. So this is the Nabucco space. You go in front. Its complete parametrium is invaded with the upper vagina in this case. It was a 9-hour case because due to her blood pressure or other concerns, the urology team decided to also take the kidney out. So their portion took another 3 hours and the case took 9 hours, as she said. So we basically now are going to cut transect the fibrotic mass to remove this portion separately. It was not easy with respect to, obviously, the assistance and the team has to be more experienced in some cases. So we approach the deep in parametrium. This is the kink of the bladder and the mass is right there. We prepare the bladder flap and eventually we'll be excising the uterus. We tie the uterine artery from this side like another with right next to the uterus, classically the way we do in every case. So there's a difference in between two sides where we tie the uterine artery. And it makes a difference because I try to bring another concept to these cases to classify hysterectomy in different stages of endometriosis. This would definitely is not the same hysterectomy that you do when peritoneal endometriosis and adenomyosis cases are given hysterectomy. So this is the ureter is being transected here. So I will be removing the left parametrial tissue. So this is the uterus coming out. And after the uterus came out, you see the parametrial and the upper vaginal involvement. And then we do this in 2 sequences. We remove the parametrium separately. So there's nothing new under the sun. Basically, the diseased tissue is easily identifiable when it is deep, chunky fibrotic mass. And in this case, the ureter is being cut right now from the bladder. We're removing with the upper vagina and toto. Sometimes it takes like debridement style removals because of the difficult to identify disease. Even after you remove, you find additional tissues around. So this is the upper vagina. This is comparable and equal to any wartime hysterectomy in a sense that you're removing parametrium, posterior vagina, and bilateral deep fibrotic retroperitoneal fibrosis. It's, in my opinion, for many, even classically described, it's harder than many times cervical cancer surgeries. So the crux after this is removed, and we remove the kidney also after the general surgeons are done from the vagina with only 3 incisions, the kidney comes out. And the cuff is then repaired interruptedly, either anteroposteriorly or vertically. We will touch these later. This is her clinical case, and I'm open to your questions as we plan this. This is for patients. This is an advanced disease, which is treatable, curable when it is this much, and certain things are done right. That's what I believe. Thank you.
Tamir, I'm surprised that the kidney was that there was abdominal incision.
Are you guys? Am I there?
Yes, you are there.
Yeah, I'm surprised that the abdominal incision was made to remove the kidney instead of doing it totally laparoscopically.
I'm sorry, Harry. Could you repeat? I was on mute. Go ahead.
The kidney was removed by abdominal incision.
No, laparoscopy, complete laparoscopy.
Right, but if you do complete laparoscopy and the kidney's free, couldn't you have removed it through the vagina?
I removed from the vagina. You saw it. The last slide was, I did remove the kidney from the vagina. Did you see not see that? That wasn't visible?
It looked like there was a skin incision there.
No. I thought that was clear. Did you see the kidney coming from vagina? Crowd?
Yeah, we did see it. Harry was asleep.
Okay, all right. The whole thing was kidney was coming from vagina. That's not
Okay. I guess I can't tell one from the other anymore.
Well, kidney does look like uterus a little bit. You couldn't tell it's kidney if I didn't tell you. All right. But the real thing is, yeah, with a laparoscopy, 3-4 incisions, all these things could be done with a dedicated team, in concert, a team understanding each other well, who has experience, can do these things. The problem is when you don't have a team and we don't have commitment to do these things.
Okay, that was great then. We're progressing on. We have, we're a little behind, but we have the next case with Courtney Brown. Will be, you have a video of her, and then you have a presentation of her operation discussion by Dr. Chu.
Hi, so I was asked to discuss my bladder mass and the effect that it has had on my life. So I was diagnosed with endometriosis in February of 2019. I had surgery in May of 2019. My primary symptoms back then were bowel problems. But when they went in there, they saw that I had endo on my bladder. There was no excision done, but they did take a biopsy. It was pathology proven to be endometriosis. Surgery went well. I was symptoms free for a week, and then I had a period. And instead of bowel symptoms, I had a lot of bladder problems. I had issues initiating my stream and burning with urination. I called my physician. They did a cystoscopy when they didn't go away. And they said everything looked normal, and they diagnosed me with pelvic floor dysfunction after surgery, just from them being so deep in my pelvis. I did pelvic floor therapy, which helped with initiating my stream and just resting my pelvic floor. And that initially helped a little bit. They also suggested I change my diet, which I did. So I eliminated all citrus, chocolate, caffeine, spicy foods. And that was extremely helpful. I also did medication at night because I would have to get up and go to the bathroom multiple times per night because my bladder just felt irritated. But eventually the pain just got worse and worse, and I started to constantly feel my bladder in space. And anytime I went to the bathroom, I would describe it as feeling like a blowtorch. Like, I actually started using the handicap bathroom so I could have a bar to hold on to because it was so painful. And the entire process of going to the bathroom with the diaphragmatic breathing and positioning and holding on to the bar and finding a handicap bathroom just became this huge ordeal to me, especially because I have a very intensive and fast-paced job. So because everything, medication, diet, therapy hadn't really worked, I started doing fluid restriction. I did that for over a year. And so first things first, I would go to the bathroom before I went to work in the morning, and then work my 12-hour shift, wouldn't go again until I got home. And then I wouldn't drink during the day, or I'd drink as little as possible. Issue with that was I started to develop dry eye. So at night, I wouldn't be able to see well. So I ended up last fall, I stopped driving at night at all. I developed skin tears underneath my eyes because my skin was so dry. And then last fall, I developed a resting tremor just because I was so dehydrated. And so I tried to rehydrate, but then at that point, I guess my bladder mass was so large that it didn't like to hold urine at all. And so I would constantly feel my bladder in space. I thought about my bladder last fall every single minute of every single day in some way. I was constantly planning, problem solving, just in case something was to happen. This is happening, what should I do? Oh, I went to the bathroom because I had to, and now it's triggered my bowel symptoms. It took over my entire life.
Was also a very educated patient. I think my associate, Dr. Amanda Chu, I think she's next to discuss her case, I guess, right? But what is interesting is she is a physician, and it's interesting. Even people may have incredible depth of knowledge to investigate this disease can take this much long, even with the most proximal profession it can be as a physician, it gets me, because we doctors, caregivers, basically divert the patient from the mainstream of other things that they are treated, everything other than endometriosis, until they realize there's a significant disease. Can we put the next video, please, or live? Who's coming next?
Good morning, everyone. Thank you so much, Courtney, for sharing your story with us. Dr. Nsechkin and I just wanted to do a quick recap of her clinical history and a small window into her surgical experience. So I will focus on the bladder endometriosis, Dr. Sejkin will focus on the bowel endometriosis. This patient, she was 31. She presented to our surgical clinic for multiple complaints that did include debilitating pain with her periods, heavy menstrual bleeding, bladder pain, and painful bowel movements. In her own words, she was only able to sit independently for a few seconds. She had to use a heating pad, a circular donut, and would cross her legs in order to shift weight away from her coccyx. To urinate, this patient learned to use the handicap bathroom as she would need medication and relaxation techniques just to void. She fluid restricted herself throughout the day, and she could have up to 8 bowel movements a day. Her past surgical history was significant. She had a laparoscopic endometriosis excision in 2019, where she only had 3 lesions excised. All 3 of those were positive for endometriosis. That surgery was actually performed at a very large, prominent academic institution. She continued care with them and obtained additional medical opinions in the following years as she had continued and worsening pain. She was repeatedly advised by multiple surgeons to take medication and told she did not need additional surgery. On physical exam, we were able to palpate advanced endometriosis with possible now vaginal extension of her endometriosis beyond her uterus and cervix. On imaging, we saw a mildly enlarged fibroid uterus. And very importantly, we were able to already see extension of her disease into the bladder wall through and through, and as well into the anterior rectum. So disease extending forward and backward from the uterus. She was counseled extensively on conservative options versus a hysterectomy. And at the end, this patient elected for a hysterectomy. So we went back to the operating room with a plan for a laparoscopic hysterectomy, a resection of both the bladder and bowel mass. And we knew this was going to be a difficult case. Therefore, we consulted urology and colorectal surgery to truly complete her multidisciplinary care team. So right at the beginning, this is a diagnostic cystoscopy. So this is a small camera inserted into the bladder. We're looking here at the trigone of the bladder. So this is the area between the 2 ureters, which is the tube that connects the kidney down to the bladder, and where the urine deposits into the bladder. So this space should be smooth. Clearly here you can see that something is protruding. There's a mass that's pushing into the back of the bladder, which is abnormal. Given this bladder mass and the case complexity, the decision was made. We instill this very bright green dye into the ureters and leave temporary stents in place during the procedure to help us see and to help protect the ureters. So here you can see on the right, the stent going in and the green dye getting refluxed out. This is just a quick demonstration of the actual video during the surgery. You can see what actually looks more like a globular adenomyotic uterus, but the bladder mass in the front, and then peeking down some rectum that's getting pulled upward. Here, just to help us see again, this is that cystic bladder mass, and very closely you can see the outline here of the Foley balloon. So you can see how close these 2 structures are. This mass is invested into the back of the bladder. Here is that nice green dye that helps us see. This is the back of the uterus with the rectum, and then the ovary is actually immediately pulled towards the inside, towards the uterus, which is abnormal. And you can see here in green, the ureter lights up. It helps us see, and again, protects this important structure. This is after several hours of dissection here. This is the bladder mass that has been finally dissected away from the anterior surface of the uterus. You can see the bladder here highlighted in green. This really helps show our borders, and the uterus is down here. So we're in this space that is generally, for most patients, preserved and clear of endometriosis. Actually, in this case, we performed the hysterectomy first. After clearing out this space, removing the uterus, given, if you look at it, its large and bulky nature, you can see it was in the way of a proper resection. So we had to stage this procedure. We proceeded to complete the formal dissection of the bladder mass. Then we proceeded with the hysterectomy. After the uterus is removed, you can clearly see here those ureters coming down very close to the cervix, but we now have space to work. Now that bladder mass is being carefully excised, that green dye you can see spilled all over the pelvis. We know we're in the right space. You can see the ureter behind, which we were able to easily see on cystoscopy, and then that mass that is at the trigone is being carefully cut out. The bladder was then carefully repaired using a suture technique. And then here it is, the same image at the end. This is cystoscopy at the end with urology. You can see that the stents and the ureter orifices have been preserved, and there's a full thickness repair that will heal very well. In total, this patient underwent a radical hysterectomy, bilateral salpingectomy, so her tubes were removed. She did need a colostomy at the end, which Dr. Sedgkin will talk about, and she had a bladder resection with temporary stents that have since been removed. Of course, this was, again, a multidisciplinary team effort with urology and colorectal surgery. We started surgery at 7:54 a.m. and we stopped surgery at 7:52 p.m. So approximately 12 hours. This patient was admitted for 13 days postoperatively, and you've seen how she is doing now. And this is just, my last slide. I want to, highlight here. She had that prior surgery in 2019. Did all of this endometriosis grow in that time? No. She had advanced stage endometriosis, I'm sure, at that point as well. And all of these specimens were taken from the bladder. So all of this was invasive, deep bladder endometriosis. All right. Thank you so much for your time.
Bladder mass was the simple part of surgery. Do you hear me? Hello? Do you guys hear me?
Yes, we hear you now.
Okay, so we started the case classic just to examine inside the uterus. There was adenomyosis, and then as she presented the case, huge bladder mass. It's about 7 to 8 centimeters. When we removed this mass and reconstructed the bladder, I thought she was going to give more pictures of this, but the bottom line is 2 ureter orifices. The trigone was partially resected, and 2 ureter orifices almost became 1 to 2 centimeters apart when you repaired it. So in order to appropriately go forward and complete removal of the bladder mass, which was extending to rectovaginal septum, we had to adopt approaching with a supracervical technique, which we use the Lina loop. This is how it's dissected. We completely excise into the residue space. We kind of freed the whole bladder and then worked on the bladder after we removed the top fundus of the uterus separated from the bladder. So this is also before we started the supracervical portion of the complete radical hysterectomy. We identify both ureters, approach to the level that we're comfortable at the parametrial areas. Similarly, we explore the posterior vagina was completely obliterated from approximately 5 centimeters above the rectovaginal septum and cul-de-sac into 3 to 4 centimeters into the anal word. So there was multiple multicentric lesions on the bowel. So we tied the uterine artery again lateral to the ureters in the same case. This is again class 2 hysterectomy, which I will be hopefully mentioning later. So the uterus was amputated with Lina loop. So we have bladder mass here and a huge problem in the rectovaginal area. So the after the bladder was, this is the vagina after the hysterectomy. The real problem comes with the bowel. So unfortunately, you rely on your colorectal surgeons, but I do all my work. So removing was like a debridement of this fibrotic mass, which was, in this case, we can use certainly infiltrative. So deep fibrotic endometriosis plus deep infiltrative endometriosis of the rectum from 3 centimeters above the rectovaginal sign all the way to the 3 centimeters to anal verge. This patient has had, in the end, this patient had 3 separate transmural nodulectomy below the rectovaginal septum. We debated because her upper high rectum lesion was very long. We had to do segmental resection, and then unfortunately she had to have prophylactic colostomy for anastomosis later, because the chances for stricture, leak, sepsis was there. Even in the best hands, this part of the surgery is highly susceptible to postoperative complications. And I must say, she's doing good, and I'm hoping that she'll have a successful anastomosis when in couple weeks ahead. I think I will end this because of the time constraints. I'm going to stop further presentation on this case. I'd like to answer any questions. I was interested in presenting this case. Simply, the endometriosis community should have realistic expectation of these surgeries. They are incredibly difficult, incredibly highly demanding for team approach, and patients should really understand. It helps when a patient is a physician, really, I have to tell you.
Tamir, wouldn't you have been better doing it? Is it 2 stages? Like bring her back to do the rectum after a supracervical hysterectomy and
no. First of all, Harry, we didn't do supracervical hysterectomy. We did radical hysterectomy. We basically, her real problem was.
I understand that. But I'm just saying, why not stop after the supracervical and let the bladder heal before you tackle the rectum?
She's almost obstructed. I mean, she has 2 things at the same intensity. Okay. Bringing it towards surgery. I mean, as you know, she main thing is bladder plus. She's going 8 times a day, but she's moving pencil thin or like a very pebble-like, very diagnostic history pops out there. She's totally, she feels obstructed.
Okay.
Yeah,
no, I agree.
It becomes a pre-surgical decision making with the patient and the team. So I think she may have had 3rd surgery if we did it that way also. Still, sure. she may have need another, either prophylactic ileostomy or colostomy. We rarely do colostomy, rarely in the last 5-6 years. Yeah. Any comments, Ray, or from the, do we get any questions from our listeners? This is for patients, really. It's important for them to understand how expensive things can get here.
I think, Tamir, you emphasized the importance of
multidisciplinary work, and I can just quote the UK experience in that after many years of this whole thing being completely ignored. In fact, my endometriosis work was officially closed down by the NHS at one stage, but they've got their act together a bit now, and the NICE, the National Institute of Clinical Excellence, has produced a document which actually says that there should be set up some national endometriosis centers, which have obviously headed by a gynecologist, with a colorectal surgeon, with a urologist, with an endometriosis specialist nurse, gynecological imaging and diagnostic facilities, and fertility service.
Now, it's a lucky person that gets all of those in one place at one time, but this should be the goal. You've highlighted beautifully in these 3 cases, really, the complex nature of this, which is almost beyond the wit of an individual person ever to really adequately not just manage, but to manage the follow-up and the care. So the idea of establishing formal endometriosis centers, funded however they may be and without a system, but with a whole group of people who are working to one goal, it seems to me more or less essential.
Thank you.
Hey, Jay.
Hey, how are you, Harry? It's Mira, everybody.
Hi. You look good.
Good. Good. I think I joined just at the right time.
There should be another presentation. You must also probably, so you could comment. But Harry, how is the schedule? Are we moving in sequence?
We are so far, but we're a little behind.
Okay.
Probably like 15 minutes behind.
I think Carly will present a bowel case, and then Jay should comment on that if he can.
We need to introduce Dr. Haas.
Yeah. Harry.
Okay. Could I? Well, first of all, since Jay just showed up, or has been here however long, let's say let me say that Jay is chairman of the Department of Surgery at Celebration Hospital in Florida. And many years ago, around 2000, Jay and I were associated. We worked a lot together. And even before that, starting in the first time I met him, I think was 1990, he brought me up to this small hospital that he was at to do a cancer of the colon, a cancer of the rectum. But anyway, since then, the last year he was the president of the American College of Surgeons, Florida branch. So we look forward to Jay doing better and better, as he so far has since leaving Pennsylvania. And I'm sure he enjoys the sunshine of Florida. Now, the next case is both cases.
This one's about the bowel. So let's progress to Carly's case, and then we'll have you discuss both of them all at once. The next case is Tracy, who's here, been here most of the morning. So, and really interesting case. I mean, her whole history is so great, or so interesting, from the disease being on the right side of the pelvis and starting with the appendectomy. But Tracy is a gynecologist who practices out in the state of Wyoming, which is, again, in itself quite an achievement, since I'm from the town of Wyoming, Pennsylvania. Thanks. Okay, Tracy, you're on.
Good morning. Yes, and as a physician, as a patient, as a board member here, I just want to, thank all of the other patients who are willing to share their stories. We're not just talking about a bowel or a bladder or a uterus. We're talking about people and their stories, and these often kind of horrific stories. And so to have a group of experts here who can comment on and validate a lot of what we have gone through is really valuable on a patient day like today. So, I want to keep this sort of brief, even though my story isn't. My endo journey started pretty early. I had only had periods for about a year when I was in the emergency room for the first time with a left ovarian torsion. I did not get diagnosed with endometriosis at that time, but years later was told that was likely my first presentation with endometriosis. I was placed on oral contraceptives, which I took for the next 15 years, despite developing lots of IBS-like symptoms that continued to last longer and longer each month. I was to the point by age 32 that I would stop eating for a few days every month just to avoid the inevitable, really severe pain that accompanied any bowel movement during periods. At age 32, I finally went to the emergency room with my severe recurring right lower quadrant pain, loss of appetite, and all the peritoneal signs that we as physicians are taught to check for appendicitis. I had pain with each step, every bump in the car, loss of appetite, even vomiting. I went to my OBGYN with these symptoms one day when it was just the worst pain ever. And she said, "You're a doctor, do you have appendicitis?" And I truly looked at her and said, "I don't know." If I was my own patient, I would probably say yes. So she sent me to get a CAT scan, which showed a grossly enlarged appendix. And sadly, I'd had these symptoms every single month for the previous 10 months. So it's just really hard to tell, and it's not always straightforward. When I ended up getting the laparoscopic appendectomy that day, the general surgeon, when he got inside, took a look and said that there was endometriosis everywhere. It was on the abdominal wall, the liver, all over my bowel. He described it as a web-like scarring that was kind of throughout the pelvis and abdomen. And he called in the OBGYN on call to come take a look. They both kind of looked at each other and decided to take out the appendix, but then just close me up and start me on Lupron. I, as a physician, young physician, was not quite married yet. I was like, Lupron is not the direction I want to go. And so I started seeking out any other options. I did continuous NuvaRing. I pursued acupuncture twice a week for 3 years. I tried to follow an anti-inflammatory diet, an elimination diet. And within 3 years, I found myself having another urgent laparoscopic procedure. And during that case, they also found advanced endo. I did finally at that time agree to do my first round of Lupron. I won't go into a lot of detail there, but I used it off and on for a total of 10 years. Despite the side effects, it did allow me to work and build a career and get married finally and travel. While off of it in 2010, I started developing even worse bowel symptoms. I had a palpable, painful, sausage-like mass in my right side. My physicians that I went to, everyone could feel it. We could all feel it. It was quite tender. It was quite large. I've been a physician who works in developing countries and disaster zones for much of my career. I'm a family physician who does tropical medicine. And because I was in and out of Haiti for much of 2010, I was sure that I had developed tropical disease. I ended up coming back from Haiti, had stool studies, a colonoscopy, barium enema, another CAT scan, and all of these were read as normal despite having this huge mass on my right side. I felt terrible on most days, and I, like so many women, I pushed on. I took continuous birth control. I took a lot of NSAIDs, and I traveled a lot. Over the next few years, I worked in Haiti and Libya and India. And right up until 2016, I returned from my final trip to India, I developed a complete small bowel obstruction. That surgery resulted in me having a lot of my small bowel, cecum, ascending colon removed emergently. It was quite an ordeal that I'll save for another day, but needless to say, once I was through that experience, I was afraid to travel and afraid to do what I loved doing the most. I was afraid of that incomprehensible pain coming back again. And I was very afraid of having an emergency surgery in another country where I was trying to help solve problems, not become one. And I really wasn't sure what to do. I didn't have a lot of options. I knew I still had endo on my bowel. And the only choice I was given at that point was to be on continuous Lupron. And I did that up until the age my sister was when she stopped having periods. So my sister stopped having periods at 44. So I said, I'll do Lupron until I'm 44. And within 6 months of turning 44 and stopping Lupron, I developed worse left-sided bowel symptoms this time, debilitating, which again kept me from being able to eat or travel. I eventually, luckily, found my way to New York, where I was able to access that multidisciplinary team that we're all here to talk about today. I was able to have more than 20 endometriomas removed, some deep. I think most of them were quite deep. I think there's some video coming up after this. I did also have adenomyosis, so I had a hysterectomy. I had endometriomas on both ureters and sort of deep in the cul-de-sac, and luckily did not have to have a colostomy, which was a huge fear of mine. Since that day, 3 years ago, post-op, I think I only had some Tylenol. I was out a couple of days later, even after a 6-hour surgery. And happy to say I've had zero pain since then. I'm off all medicines, working, and just getting back into traveling again. So thank you.
Thank you so much for sharing, Tracy. I just have a few slides in summary for all the physicians on the panel. So again, and I like to call this one 20 years of birth control and Lupron and 2 bowel resections later, I think Tracy's case really highlights the amount of medical management she attempted for many, many years. And despite that, the degree of endo that continued to progress in her case. So this is a long slide, but we'll just try to summarize her surgical history one more time. So at age 17, she underwent an exploratory laparoscopy emergent surgery for ovarian torsion. At the time, there was a blood-filled cyst. Afterwards, she was started on birth control pills, which she continued on for many, many years. At age 32, she had a ruptured appendicitis, had a diagnostic laparoscopy, and endometriosis was found. She was started on NuvaRing after this, continuous. At age 35, she had laparoscopic endometriosis ablation and was put on Lupron suppression for 6 months afterwards. And at age 42, she had an emergent small bowel obstruction, and at this time underwent bowel resection, ileocecectomy, removing part of the ileum and cecum, 15 centimeters of small bowel, and part of the ascending colon due to adhesions and stricture. Again, she was placed on Lupron suppression afterwards and also norethindrone. At age 45, 3 years later, she was off of all medications for a year, and the bowel symptoms and severe pain returned. She was put on Lupron again and norethindrone combination. However, at age 45, still that year, she underwent, the medications were not working. She still had severe symptoms and underwent laparoscopic deep excision surgery with removal of 20 specimens, endometriomas, and another bowel resection, this time large bowel. At the time, also total hysterectomy with bilateral fallopian tubes taken out, and both ovaries were preserved. These are some of the pictures from the surgery, and this is deeply infiltrating endometriosis, as we can all see, nodularity, and extensive pigmented lesions, as well as deepened nodularity along the course of the ureters underneath the ovaries. And these illustrations show deep fibrosis and endometrioma chocolate fluid nodularity along the course of the ureter, which is the pathway from the kidney to the bladder. These are areas of her sigmoid nodule with kink in the bowel that was found. Thank you so much, Tracy, for sharing your story again. Hi again. I thought I'd present this time on a question that we get very commonly in these patient days and in education we do for endometriosis patients all over. So a very common question a lot of you have is hysterectomy the final answer? And is hysterectomy a cure for this disease? It's a great question. And there are a lot of patients out there that may still have pain or issues after hysterectomy. And so I want to highlight some reasons why. And so the title of this is hysterectomy the final answer, and why do I still have pain, right? So hysterectomy alone is not the final answer. Hysterectomy refers to removal of the uterus itself. It doesn't refer to removal of the ovaries. It refers to the uterus itself. Many people think it refers to ovaries as well, but that's actually a misnomer. So if it's hysterectomy with oophorectomy, that's removal of the ovaries as well. If hysterectomy is done alone, endometriosis is by nature an extrauterine disease, meaning it occurs outside of the uterine lining. And if the endometriosis deposits are left in place and only a hysterectomy is performed and all of the endometriosis is left in the pelvis, the patient can still have symptoms. And if deeply invasive disease is left behind and the ovaries are still in place and only the uterus is taken, then the ovaries will continue every month to fire up with ovulation and fire up whenever the patient may have had their bleeding menstruation, their period. And all of those lesions that are still there in place can be stimulated and symptomatic. And that's why it may feel as if nothing really happened, as if they got rid of maybe a little bit of the cramping and the bleeding, but all of their other symptoms are still there. And this is why. Further stimulation can occur. Hysterectomy, if performed with deep excision of endometriosis and possible ovarian removal or oophorectomy, can be much more therapeutic for the patient and even a definitive surgery for them. And obviously, ovarian removal is very controversial, right? We have to take a lot of things into account when discussing this with patients and deciding what to do as far as ovary removal. And even if they are left in place, we always recommend that the patients are very closely monitored, especially if they have a history of ovarian cysts in the past. And so all of these, this is obviously an informational session, education for patients. This is not a, patient decision-making forum here, but everything that we do is individualized case-by-case scenario for the patients. So this is just some quick pictures of evidence of endometriosis after prior hysterectomy. And we can see in the small picture starting on the top right is that there's multiple endometriosis lesions throughout the pelvis. During this case, the patient has a rectal probe in place. We see the bright green light of the ureter, and we see multiple endometriosis lesions with color all around the pelvis actually that were still there. And so this can be found in many cases if the endometriosis was not treated at the time of the hysterectomy with removal. And as far as what we were discussing before with ovarian planning, we always have to take into account the age of the patient, if they're planning for hormone replacement, balanced until they're age 51, which is actually recommended by American College of Obstetricians and Gynecologists. If they have ovulation pain, if they have a history of ovarian cysts and endometrioma in particular, if ovaries are left in place, the recurrence rate or reoperative rate could be as high as 30%. And it's important to note that the endometriomas and endometriosis in general is the only known precursor of ovarian cancer. So we do counsel our patients that they should be closely followed as long as the ovaries are in place. And if they're doing hormone replacement, with a sonogram yearly, and just follow up with their endometriosis care surgeon if possible, or a gynecologist. If hysterectomy is done first and endometriosis is removed, the ovaries can actually be preserved and just watched closely. And then at the time of menopause, the ovaries could be removed to help prevent ovarian cancer and significantly reduce the risk later. And again, every patient, we go through a customized approach, hormone panel preoperatively, all of their symptoms, and we watch them closely. And then if there are areas of hormone replacement, we do this with a balanced approach. It's recommended not to use estrogen alone in endometriosis patients. These are a couple of cases, just for example. This is a 64-year-old patient that had a lot of right and hip and leg pain, and she was followed for kidney pressure and kidney failure, actually. She had a hysterectomy and ovaries out 5 years ago for endometriosis, and the appendix was taken out. Only one area of endometriosis was excised at the time of her hysterectomy. So she came in with constant right hip leg pain, and she went through multiple doctors, physical therapy, tried all different things, and they said, you're just gonna have to live with this pain. Her CT showed actually moderate pressure on the kidney called hydronephrosis, a swelling of the kidney. And she was offered kidney removal, actually, instead of finding the root cause of why this was happening. It turns out that this patient actually did have endometriosis still, and she had laparoscopic excision of endometriosis with a large fibrotic area that was found on the course of the right kidney to the bladder, called the right ureter, at the psoas muscle, right wrapping around her hip where she was having most of her pain. And all of these areas were positive for endometriosis. And this was many years post her hysterectomy and oophorectomy and many years post-menopause for her. And so after surgery, she did very well. Her right hip leg pain was gone and she was able to preserve that kidney. These are just some pictures of the course of the ureter and the disease surrounding this area. And another question we get a lot on these forums is postmenopausal endometriosis. Is it possible? So a lot of patients are told endometriosis goes away with menopause, and if you just hang in there till menopause and keep taking Lupron or different medications to get you into menopause, then this will get rid of endo. Unfortunately, that's not the case. It's not magic. Many people may find relief from menopause, or these menopause-inducing drugs. However, it doesn't get rid of the lesions necessarily. And we found that on case and case again on actually looking inside the abdomen and seeing what is there. And we'll just show you a little case about that as well. This is a 71-year-old female who had one miscarriage and a vaginal delivery, extreme inflammatory symptoms, bladder frequency, inflammation, always felt like something was crawling inside of her since her 30s, gas, bloating, and leg fatigue on both sides. Not a lot of pain itself, but just not feeling well overall. Her daughter had endometriosis, extensive on laparoscopy, and she was never offered a laparoscopy when she was younger. She had laparoscopic investigation for endometriosis and actually had 17 out of 21 lesions positive for endo at age 71. And so these are the pictures, which is very interesting. So her lesions are no longer chocolate colored or colored, but they're clear and they're very much present. You can see there is a large nodule on the left picture, and you can see on the bottom right picture, there's ovarian adhesion still, even with the postmenopausal small ovaries, and there's still all these white lesions of endometriosis that have basically just changed in pigment or color. And so, these cases really illustrate that it is possible to still have postmenopausal endo. It is possible to have endo after a hysterectomy if it's not really excised all the way in the beginning. And we really recommend, if you're having a hysterectomy for endometriosis, that you have deep excision of endometriosis at the same time of all visible lesions, even if they're teeny tiny 1 millimeter, to really reduce your risk of having symptoms in the future if possible. And these are just a couple of different studies highlighting hormone management for women with menopause with a history of endometriosis. And it's still quite controversial, but there are major governing bodies in the US do recommend not using estrogen alone in patients with endometriosis because it could further stimulate microscopic disease or small areas of disease. And they do recommend a balanced approach to hormone therapy and close monitoring. And so further studies do need to be done on this, but typically we take a combined approach with our patients as well. So I hope this helps several patients with some answers, and I wish you all the best of luck. And thank you. Let's see. Yes, this is what we just said. This is estrogen, progesterone recommended, and caution is advised using estrogen alone. And for more information, thank you so much. We can check out EndoFound and drsechkin.com or Endo Fertility. I'm working on some fertility and hormone information on there for patients as well. Have a great day, a happy March, and hope all of you continue to be well. Thank you.
We want to discuss bowel endometriosis, and I'm not sure we have Jay here, and I'd like to have Jay discuss the last two cases, if possible. A lot in one sentence. Thanks.
Yeah. And thanks, Dr. Rich, and thanks, Tamir and EndoFound for a chance to be here today. As Dr. Rich knows, we've been working together for over 30 years now. Got me when I first got out of training. I said, well, this is an interesting disease. We learn a little bit about in surgery training, but the more I've seen over the last 30 years, actually I'm a little bit disappointed because not much has changed over 30 years. So I think the way to move forward is to think about this, as Dr. Gary was saying, this is a multidisciplinary thing. Most gynecologists think when they see stage 4 endometriosis, think they're seeing a stage 4 cancer. and they think it's untreatable, unresectable. They need chemotherapy, i.e. Lupron or Lissa or some kind of medicine. The average patient, and that's not true. Endometriosis is not a malignancy. It's not a grade stage 4 cancer. It is a grade 4 disease. And that's when we see it outside the pelvis and into the bowel or ureters and bladder, etc. The treatment is not chemotherapy or Lupron or Lissa. Those tend to control symptoms, but the treatment is resecting it. And that's why we need to have a multidisciplinary approach. We actually, when we have these kind of cases, do kind of like a mini tumor board. We examine these stage 4 endometriosis cases in a tumor board type setting. We get the opinion of the surgeons, gynecologists, the urologists. When necessary, we have nutritional counseling, we have smoking cessation, we have psychologists, as many of these people have a lot of stress. We have exercise physiologists. And that's what led us to publish an article several years ago on what we call CAPS, complex abdominal pelvic pain syndrome, because endometriosis is a single disease in and of itself. However, many times it involves many other systems, and it's not just a diagnosis, it's a multi-system approach to dealing with this problem. We know historically, in our experience at Celebration Health over our last almost 20 years there, an average patient that sees myself or Dr. Steve McCarris is the gynecologist I work with mostly, and I'm sure many of you are familiar with his work. An average patient has had at least 7 laparoscopies before they even see us. So by the time we see a lot of pictures, usually what we see is people just try to burn the disease. And unfortunately, frequently when you burn endometriosis on the bowel, you get a bowel perforation. When they burn something near a ureter, get a ureter injury. And they burn something near the bladder, get a bladder injury. That is not the correct way to treat this. I think there's a massive education that needs to be promoted throughout the gynecology societies to realize that there should be a multidisciplinary approach. Don't take it on your own. I think gynecologic oncologists in general are probably the best currently available treatment, since they understand bowel resection, bladder, ureter, the whole multi-system approach. We like when patients come to us that someone has taken several pictures, preferably biopsy what they suspect is endometriosis, because many times we see hemosiderin-laden macrophages. That's not endometriosis. That is blood in some cells. Even though it may look like it, the only way to definitively diagnose it, as is to definitively diagnose a cancer, is to get a proper tissue diagnosis. No guessing. We don't like guessing. Proper workup and evaluation, including MRIs of the pelvis, is very helpful. Proper evaluation of the bladder, urodynamics sometimes is helpful. An examination of the bladder. We've seen all these horrific cases already. I think all these horrific cases possibly could have been not so horrific if they were properly diagnosed and evaluated before the first surgical approach. And I think that is where we need to put our efforts into making sure people get the correct early diagnosis early on, and that'll certainly help make our surgical multidisciplinary approach much easier, much more successful, because as we all know I think everyone will agree on the panel here, the definitive treatment of endometriosis is to excise the endometriosis. We don't have to remove normal organs. A lot of times the uterus is normal. It's the endometriosis that's affected. It's kind of a symptom or a bystander of the disease process. We don't have to make all these clearly females, infertile by taking out all their reproductive organs and still leave the endometriosis behind, as we've seen in the last 2 cases. Proper consultation with our infertility experts, possibly storing their eggs ahead of time. These are all important things to consider. So I really think, even though we're seeing these horrific cases, we have to go back about 17 steps before they even get to the part of being these horrific cases to utilize our multidisciplinary approach, team effort, proper utilization and hopefully in a center, as Dr. Gary said, that I think the Endometriosis Foundation of America can help strengthen to make sure people get the proper treatment at the proper location with the surgical, gynecologic, and urological experts, so we don't have all these horrific stories that we're hearing about today. I'll just stop there for right now and open to any discussion. Certainly, I can more than willing to comment on these cases. However, I think the overviewing point is that we shouldn't have to be seeing these horrible cases. They should be taken care of and be done with it, and have the people that have endometriosis cured with correct and excisional treatment. Thoughts there, Harry or Dr. Gary or Tamir? Anyone else, Dr. Haas?
I think what is most striking with these two cases,
there's a prolonged treatment of birth control pills, and despite
the disease continued to progress. It's unfortunate. There's a line and group of endometriosis. If the disease is settled in pelvis, there's no halt of progression. There's something uncontrollable, disease goes. We've been seeing these cases right and left. They're 10 years, 15 years on birth. So early detection, early diagnosis, and proper and timely intervention without jumping at early age probably halts the disease progressing with, provided that there is hormonal suppression of the ovaries and menstruation. So these multiple bowel surgeries, multifocal, multicentric bowel disease, but general surgeons dive in. They don't really do the pelvis. They do everything else, appendix, ileocecal, whatever, and then pelvis is left, and the patient never knows how bad things are down there. I think proper documentation with pictures and even videotaping. We videotape all our surgeries to really measure our own experience, and later to visualize if the patient recurs is very, very helpful. And that really brings significant validation and transparency and trust that is so much needed in this field. As you say, it's been 30 years. Yeah, in certain areas, we have to be a little bit fair. In certain, now there's more interest, the disease is more diagnosed, but the quality of surgery is still debatable. However, there's more grouping of people trying to do this. And I think, I'm hopeful it's going to take maybe another 10 years, but there will be more organized centers doing this.
So I agree. I can expand a little bit. I know the surgical treatment has changed a lot. There's, certainly a lot of people are doing with the robot now. I actually have a talk I do going from driverless cars to surgeonless robots. So what I do is take the map of the CT and MRI and port it into the robot and let the robot excise it, maybe with more precision than the surgeon, because still at this point, the surgeon still has to operate the robot. And I still think, even though we're talking a lot about laparoscopy and robot, there's still a significant role for open surgery. It's much, as I tell our fellows, it is much better to do a good open operation than a bad laparoscopic or robotic operation. I'd rather open, because the 2 months, they're going to be the same. And hopefully at 2 months, they won't have their ureters cut, they won't have holes in their bladder. They may have a temporary diverting ileostomy, but in the long run, the most important thing to a patient is to have their disease successfully cured, not the modality that's used. So it has to be in a place where people know how to, all approaches at this point still, until the robots and our surgeons evolve. But it takes a highly skilled, trained team to do this properly.
Jay, most endometriosis meetings, we talk a little bit about the bladder and the rectum and the left side of the pelvis. Today, we had a very interesting case discussing the right side of the pelvis, Tracy Haas's case, with which started off with what the doctors thought was appendectomy. So, could you discuss that for a few minutes?
So, yeah, as we all know, endometriosis is going to show up anywhere. I think most docs, most surgeons don't realize it until they get in there, and they're not really sure because they haven't seen it a lot. certainly from a surgeon's point of view. If you go in thinking for appendicitis, yeah, you take out their appendix. A lot of times anyone with endometriosis, I take their appendix out anyway, because anytime they come back to the emergency room with right-sided pain or abdominal pain, they're going to get the ABCs of emergency medicine and begin CAT scan. So they're going to wind up with 10,000 CAT scans. And if with their appendix is out, then the ER docs or ER practitioners, I should say, nowadays aren't so worried about it if the patient knows they have had their appendix out. So that's the correct thing to do. As far as seeing it on the right side, certainly we've seen multiple endometriomas on the right side, left side, whenever you do it. And we have a plan. When we go in to do our laparoscopic or robotic or open exam, we always start from an area of known to unknown. So we follow the colon, or we follow the rectum, or we follow the uterosacral ligaments whenever you can see them, and then attack the endometriosis from going from known to unknown and restoring the anatomy. I think people get in trouble when the anatomy is so distorted they can't see anything normal. And really the point is you have to go back until you find a normal area, and then trace the known anatomy down the proper location into the pelvis, excise it off the posterior surface of the uterus, excise it off the posterior surface of the cervix. You can, once you get by that, then we always find the rectum where it's softer, because it usually does not go down to the anal verge. There's always a softer part once we pass the uterosacral ligaments. And then we usually, in block resection, transect the rectum there and mobilize the sigmoid colon. Maybe need to mobilize the splenic flexure to get it reached down to the pelvis. And if it's that bad, then we'll do a temporary diverting ileostomy if we need to protect our anastomosis. And that's been our most successful way of really eradicating the disease in the pelvis. We certainly do discoid resections, as you taught me, Harry, back in the 1990s, for small isolated lesions. That works great. But we do not, we do think the best way is to do an end block resection. We usually take the uterus with the rectum together if it's invading into the uterus, and then remove it in one, and then restore the anatomy back to normal once all the disease has been removed.
I have a quick question for you. In my case, I had my appendix out when I was 32, and there was endo all over my bowel, or at least that's what they had said. Would you have advocated for a bowel resection earlier? I ended up having one, 12, 13 years later, but that with a lot of suffering in between. And I just wonder now if you would advocate for that.
It would really depend on your symptoms and what everything looked like at that time. If you weren't having any bowel symptoms at the time of your appendectomy, I probably would not have, unless we got in there and something looked stricturer at that point. Almost everyone that I see certainly has bowel symptoms of some sort by the time they come and see this. So we do a colonoscopy certainly ahead of time, pelvic exam, rectal exam, MRI of their pelvis, follow their, track what their urinary symptoms are. We do a pelvic pain inventory, and then we really need to identify what's the expectations. If it's someone that still wants to have children, we get infertility involved to see if we need to store eggs or not ahead of time, or a surrogate if they think they're going to need hysterectomy. We have we do bowel motility studies to see if it's a physiologically obstructing lesion, SITS markers studies as well, to identify bowel transit. Is it a intermittently symptomatic bowel issue that happens with their periods? That may just be a small lesion that expands and contracts with their periods. So every patient is different. We treat everyone individually. Everyone's stories are different. And that's why we utilize such a large multidisciplinary approach to prevent infertility, to prevent unnecessary surgery. And if we're going to perform surgery, make sure we get everything out at the one time, and people are cured of their endometriosis. We utilize Lupron sometimes pre-op, kind of like neoadjuvant chemotherapy for rectal cancer, to stop the inflammatory process, but usually 3 to 6 months before their definitive operation. Certainly not a lifelong thing. Orlissa I think, is a fairly useless drug, personally. But again, I'm seeing a skewed distribution of patients in my practice now.
6.
Thank you.
Sorry.
Any other comments, thoughts, or any patients that have any questions?
Hi, everyone. I'm Judy Ju. I'm a chef, a restaurateur, an author, and also TV personality. And I also have endometriosis. And I've had quite an interesting journey with endometriosis. I actually had very, very progressed endometriosis, frozen pelvis, stage, I don't know, is it stage 5? I don't
Can
know
you
what that-
please? Yeah. Okay, thank you. So my question to you, we all learn through others. Harry learned from others. The others
that Harry learned from others. So this is a 100-year-old disease, which is more than 160-year-old disease. Somebody defined 100 years ago, it's endometriosis. Many of that guys, whatever he said, Samson, is still holding today. Samson did not have all the fancy things that we had, but he accurately targeted the right direction. The question is, what did you learn as a colorectal surgeon from the beginning, and now you can do safer surgeries? What do you do extra to prevent stricture of the rectum? What do you do extra to prevent leak? What do you do extra to have peritonitis or distorted or this bowel dysfunction? These patients continue to also, even though successful surgery, their bowel function may not really adapt well. So what did you learn? What is that trick there?
So I think a lot of, as I mentioned there to me, several things. First, when we do rectal cancer, you know that they've had pre-op radiation, and chemotherapy. So there's a lot of fibrosis, and I think our experience shows that we're used to this fibrosis, and not dissimilar from endometriosis. So that's one thing. So we need a normal place to hook up to. Since it's not cancer, there's almost always a place proximal to the anal verge where we can transect the rectum at this point. So preoperative endoscopy is essential to identify the lumen, and pre-op colonoscopy to identify the rest of the colon. What we do is we check the blood flow. I saw ICG mentioned before. We can check the blood flow to the anastomosis. We check our donuts when we do our staple. What we also do is do endoscopy. At the end, we do what we call as a flat tire test. We put lactated ringers in the pelvis and then do a endoscopy under pressure to make sure there's no air bubbles coming out of any of our staple lines or excision lines. And that has worked great for my last 30 years. If there's any question, we do a temporary diverting ileostomy, give the anastomosis time to heal. We don't put our anastomosis near the vaginal cuff closure, so you prevent a fistula that way. We also will keep a Foley in if we have to do any bladder repair for about a week to keep the bladder decompressed. Hopefully, we put our suture line on the dome of the bladder. So again, it's not near the vagina or near the rectum. We want to keep our anastomotic suture lines away from each other. And that's important. I think there's an excellent point that Dr. Rich made before. There's no danger in doing a staged operation. I'd rather come back 2 or 3 times on separate occasions to prevent a fistula or some kind of abnormal communication between any of the organs to allow it to heal. We're not, we want to win the war. We don't want to win the battle, so to say. So
that's a good point. And also I do use omentum when we have multi-organ sutures, ureteral anastomosis with hysterectomy, bowel resection. Sometimes all of these are done together. You have no choice. And whether that protects or not, obviously it's open to discussion.
I know I use a little voodoo doll and a rain stick. That helps, I think, just as well. So
okay, right.
I think just keeping your suture lines away from
just
each other.
Just like drains, right? Yeah. Okay.
Yeah, drains don't now, except in a bladder. Bladder, you need to put a drain in to make sure there's no leak. But otherwise, there's not necessary to put a drain. As far as recovery, we do. I wrote my first article on enhanced recovery. 2011. We do frequent use of tap blocks, laparoscopic or open. We heat and humidify the fluid, just as Dagat mentioned, the gas, as Dagat mentioned, because we know that helps decrease peritoneal inflammation and helps healing. Early ambulation, we don't use NG tubes anymore. We get people up and around. As far as post-op pain control, we alternate IV acetaminophen with IV ketorolac every 3 hours. So the patients are always getting something on a scheduled dose when they're in the hospital, keep the narcotics to a minimum. There actually is a new gel that we've just finished one of the protocols on called Zin Relief. It's a bupivacaine meloxicam gel we put in the incisions, and it lasts for at least 3 days and numbs things. You don't have to inject anymore. So that's another really nice product that we started incorporating into our protocols.
Would you ever do an omentectomy or something with omentum, like Tamir mentioned, pulling it down to prevent adhesions? I have no experience.
No, I think that's voodoo. As soon as they get up and walk, it's going to move. You know, people use some 3-0 silks. I can't believe a 3-0 silk's going to hold something in place. They're just going to tear out. I don't think that matters. It creates more adhesions for sure if you leave it down there and it stays. And then we get another case out of it. We get a bowel obstruction later when the omentum's stuck down there. So.
Okay.
I'm being facetious for all the patients that are listening. So it's not wrong to do. I just don't think it's, my gray and missing hair experience says it doesn't work.
Great.
Thank you, Jay. Thank you so much.
Oh, and one last thing. I know you asked me to show to me or some of my other my other patients.
Yeah, your other patients in
other
Orlando,
patients, yeah.
Real ones.
So my other one, you guys see my, let's see. So you see some of my other patients here now. One of the other good things we get to do is I get to go to Disney, and it's one of my recent hysterectomy patients. Can you guys see that? So we get to, I know Tamir gets to operate on movie stars. I get to operate on the Disney stars here. So there's Rafiki. As you get, if you can see the tiny little incisions from Rafiki's laparoscopic hysterectomy. So
they'll remember you.
Yeah, see here the little incisions there. I even used her belly button there, Harry. So. So these are kind of the important things I've learned from my gynecologic colleagues. I take care of some of my 5 minutes down the road. I go to Animal Kingdom and take care of some of their patients when they need laparoscopic and minimally invasive surgery. So,
Jay, I thought you were going to show some elephants.
Oh, we have our elephant trocars. I'll have to save that for another time. I got some bongo antelopes. We have I got some goats coming up.
All right. Wonderful. Thank you so much.
All right. Thanks everyone. Thanks for having me. Appreciate it.
Of course, we're honored.
Thank you very much, Jay.
Good.
Great.
See you guys.
So
would you
answer?
Yeah.
Now we're going to talk about food. Now we're going to talk about food with Judy Jew about food for everyone from Diet Guru and Chef Judy Jew. I think
is that why you've moved to Italy, Harry? You seem to have moved somewhere nice with your background there.
A lot nicer because my other one wasn't showing up.
So Judy Jew is a very celebrated person in London. She has her own chain of Korean restaurants, and she has a food show on one of the channels in England. She is an investment banker. She was in New York. For the food of love, she moved to London. And
where else?
Where else? Okay.
Hi, everyone. I'm Judy Jew. I'm a chef, a restaurateur, an author, and also TV personality. And I also have endometriosis. And I've had quite an interesting journey with endometriosis. I actually had very, very progressed endometriosis, frozen pelvis, stage, I don't know, is it stage 5? I don't know, like the highest level. But coincidentally, I was relatively asymptomatic considering how progressed my disease was. And I attribute that mainly because I was just naturally and instinctively just eating an anti-inflammatory diet on a regular basis already. And I think that that really helped in terms of not having very many flare-ups, not having very many symptoms, and also just managing my endometriosis. In some ways, I think if I had more symptoms, I would have sought out surgery sooner and I would have had a much easier surgery. So it is a bit of a chicken and an egg, but because by the time I got to the surgery table, it was just everywhere. But at the same time, I think this is a lesson for those who don't have as advanced stage of endometriosis, that you can really manage the disease and the symptoms through good balance of diet and exercise. I am Korean and I specialize in Korean food, and I think that's probably one thing that really helped, because we inherently very firmly believe in eating a lot of vegetables and a grand variety of foods. If you've ever sat down to a traditional Korean table, you would notice that it's always like laid corner to corner with lots of little small dishes. And those small dishes have many different types of vegetables and many different types of preparation. And this goes into the fact that the Koreans believe that you should have the five flavors, the 5 colors, and the 5 textures in every single meal. And I think this is good words to live by, because it's all about balance and harmony. And you want to be able to eat a wide biodiverse meal, because then you're going to get lots of different types of vitamins and nutrition, and you can feed your soul and your body. I eat very little red meat. That's just me. It's nothing that I tried, but I just gravitate more towards fish and leaner proteins, and particularly fatty fish. So things like salmon, which is great omega-3 and great omega-6, and also sardines and mackerel. These are all really good for you. Tofu as well. A plant-based diet is also very good, but do stay away from processed foods no matter what you do, even if you're plant-based or vegan. A lot of these kind of lab-grown fake meats are not so good for you. They're full of additives and stabilizers and all kinds of things that your body's not really meant to break down that naturally. So try to eat the seasons, eat a lot of fruits and vegetables, have a wide array of things. In Korea, we're harvesting from the sea and the mountains and the valleys, and have lots of root vegetables and sea vegetables and seaweed. So try to explore, expand your repertoire. Try not to have too much red meat or saturated fats. Just really eat fresh is what I think is the main kind of goal here. You just don't want to eat processed foods. Of course, you don't want to take away the joy in life, and I'm all about that. You have to still have joy, and if it's your birthday, eat the cake and drink too much or whatever. But just the next few days afterwards, just find that balance. It's all about the balance, and food is celebratory. Food is not the enemy. Food is what helps you think and grow and be strong and gives you energy to function in life, to play and to work. So, make sure that your food choices are just wise, and you can absolutely make food that is healthy, that is within the anti-inflammatory diet, that is easy to digest, that is also extremely tasty and extremely full of flavor. So I think that look to I think more Asian foods, maybe, because we naturally don't have dairy or cheese or a lot of these kind of more saturated fats that you find in like butter and cream, etc. And most of our flavor comes from spice and fermented things. Fermented things like kimchi are also very important. I think that you need to pay attention to your gut biome in order to crack your overall health, in order to kind of have good digestion, and to have your everything kind of working properly. You have to pay attention to your gut biome, and that also supports the rest of your body. It supports your immunity. It supports hormonal balance. It supports your insulin levels, and making sure that you don't have insulin resistance and everything is working properly. And so I like to say that the food is part of your journey towards health. It is part of medicine. And if you have a healthy and good anti-inflammatory diet in conjunction with being under the guidance of a doctor in Western medicine, I think it is completely a recipe for success. And hopefully you can have endometriosis without any flare-ups. I haven't had a flare-up in years now, and I'm living a very active and fulfilling life with endometriosis. So it is possible. Thank you, everyone.
You know, we're down to our last case presentation. So for that, we have a video, and I'll make some comments afterwards because I think Dr. Redan left us. Go ahead.
My journey started when I reached out to Dr. Seshkin's office back in October to complain about a bubbling, airy sensation on the right side of my chest, alongside shortness of breath. And I was feeling that months before I made the phone call to his office. I thought that I was dealing with muscle tension. We're also during that time deep in the pandemic, so I thought that it was COVID related. But I noticed that this sensation would always come during my menstrual cycle. I went to different doctors, primarily through urgent care, talking about my symptoms, thinking it was COVID, but my x-rays came back normal, EKGs were fine. And I just knew that I have to seek a specialist. So I was told by Dr. Seshkin's office to go for an MRI and a CAT scan while I was menstruating. So after the CAT scan report showed that I had a pneumothorax, I was rushed to the emergency room. A chest tube was placed and the surgery was scheduled, but my lung collapsed again and my surgery was expedited. And during the surgery, they found about 20 lesions, and 4 lesions were found in my diaphragm, which was contributing to my frequent lung collapses. So I just want to stress that it's important to really understand your body. Whatever doesn't feel right, seek the proper specialist to help you come up with a plan that is necessary for you. And this foundation is the best place to me to start with getting the amount of information that you need and putting out the proper awareness. So I'm here to say that my name is Chika and I'm managing endometriosis. Thank you.
Tamir, are you going to talk about it?
I am going to talk about it, but I think Amanda has some clip on it. I can share my clip on this. You know, in general, let me start with mine. I think we have an issue with technical issues a little bit. So let's see. So Chika was one of our unique patients that we have been dealing with. Here we go. This is not really okay. So, are you seeing my screen?
Yes.
Okay, so I think Amanda has full story, but let me see what I can tell about Chika. Chika was a patient of ours we've been communicating with her for endometriosis. It's important for me to tell you that over the last 3 years, extensively, we've been treating thoracic endometriosis. So it's extremely rare, but the way this whole internet and everything works, we've been getting these patients as patients discuss amongst themselves, however it is. So my position is, obviously, in general, I will be presenting more than 40 cases we have next week, but this is something, a teaser for us for next week, presenting these 40 cases. Endometriosis is a progressive disease, and average age of these patients are 37, and Chica was 36. And many times these patients have subtle pneumothoraxes. They don't even know it is, and nobody knows. They all miss it. And one day it comes with full picture. Thoracic surgeons go in and they do, put a tube. They then do pleurodesis. They don't know how to recognize endo. They miss the hole there in the diaphragm. They don't understand it. And I have patients who had 16, 15 chest tube placements. It's very interesting. So she came in again. I suspected this in her just simply because of history. And I told her, look, just drop to the emergency room if you're short of breath again. And she did. She did. And she came in. It was a repeat pneumothorax. Many times, our chest surgeons now know this disease, but many of them admit that they had no idea. Even though this was first described by thoracic surgeon in 1956, Catamenian pneumothorax. So most important thing in her case, when you look at the diaphragm, you don't see anything, but you're not seeing the whole diaphragm here. There is a central tendon here underneath over the liver dome. This is falciform ligament. There's a coronal ligament here. You need to use 30-degree lens to see it. I mean, these fenestrations and irritated, disturbed inflammatory peritoneum lichen pelvis continues to be here. This is a small video. This is the purpose I'm doing this, because if you don't look for it, if you don't suspect, you're not going to see it. You're going to miss. So I'm pressing down with my liver retractor. I have 30-degree lens. It's coming. There you go. There is the hole, and you see the whole picture through the diaphragm. This is very thin. This is central tendon, and almost 99% of the time, the holes are here, and it needs to be recognized by the gynecologist, and the team worker, thoracic surgeon has to work. I think in my I have excises from diaphragm here, but I have to admit, it's best recognized and done through the chest by thoracic. 70% of these patients have advanced deep endo in pelvis. This is Chica's case. She had fibroid uterus. We removed her fibroid, repaired uterus, and removed the fibroid from colpotomy. Both ovaries were freed and both ureters are freed. And this is what the thoracic surgeon does robotically. And we can do it by standard stick surgery. I have also helped them, assist them, and I repaired diaphragm from above. Thank you for their trust. But I think robotic surgery is somewhere here. It's very steady and very controlled, I have to say. We have more of these cases to be presented next week. But I want to tell you, this is endo, guys. This is stromal endo. I have pathology slides for you, and it has to be recognized and excised. It's in this case, we have also had a parenchymal endo along with diaphragmatic endo. You're going to see these next week. And this is my aqua blue contrast technique, which I really blow the retroperitoneum and bring these fibrotic elements. These are all excised in toto. And this is her myomectomy. This is her colpotomy as we repair. Thank you very much. I think that's all I'm going to tell at this stage, and I'm open to your questions
about Chica.
Listen, once you do it through the thorax without a thoracic surgeon, well, Jay and I did it, back the second time I operated with Jay was 1990, and it was somebody with a achalasia around a big band around her feeding tube. And I said, "What's this that keeps getting in the way?" And it was the heart. So it's the only thing you see when you're in the chest is the heart. So, but with endometriosis, you see a big lesion, and you could remove it well and sew it up well through the chest with no obstructing bowel to worry about. Just my own experience, because I know Jay would say the same thing if he was here.
No, but we have a lot of experience on this area. Many times you don't see in the chest typical endo lesions. Really, it's interesting. You may see it, but very little. It's the bleb that's caused on pleura. It's the hole on the diaphragm. When in microscopically, then you see endo. It's physically, you don't see it like you see in the pelvis. It's different.
It's very impressive the way you showed that hole in the diaphragm.
You're going to see so many of them. It's so exciting, but you got to be on the other part of the diaphragm. That central tendon has to be completely visualized.
Okay.
Thank you. And Chica is doing exceptionally well for me to report. She's wonderful.
Very nice.
Good. Very impressive. Very impressive.
Okay. Now we have Amanda. Is she Amanda?
I think we should skip her Chica portion. Amanda has a centralization of the pain issue, which is very important in these
has a discussion of pain.
Yeah.
Which I think if you have that video, it would be very good to show.
Thank you so much for the opportunity to speak. The title of my talk is Endometriosis. Why does it hurt? I really want to address the question of, if I had surgery, why do I still have pain? If I'm doing this X, Y, and Z intervention, why do I have pain still? This is a pretty big topic to cover in about 20 minutes, but we'll go over some of the basics. I have no disclosures related to this topic. The objectives of my talk, I want to talk about the common symptoms of endometriosis, discuss different types of pain, discuss the ways in which endometriosis can cause pain, and then discuss very general principles for pain management. As we all know, endometriosis is a complex syndrome of estrogen-dependent chronic inflammation that primarily, but not only, affects the pelvic organs. Most often, it results in chronic pelvic pain, so that is up to 70 to 80% of all of our patients, and infertility. It can affect up to 1 in 10 reproductive age women, and unfortunately, still today, there's about a 6 to 10 year delay to diagnosis. Common symptoms of endometriosis include painful periods, so dysmenorrhea, heavy periods, heavy menstrual bleeding, painful intimacy, dyspareunia, a multitude of bowel symptoms that include gas, bloating, diarrhea, constipation, painful bowel movements, urinary symptoms, back, leg, hip pain. 20 to 25% of women, though, have no symptoms. So that's what we consider, quote, silent endometriosis. Where can endometriosis go? It can go to a number of places, most commonly the ovaries, the peritoneum, which is that smooth, silky saran wrap-like layer that covers most of the organs. It can go to the bladder, bowel, and even to places like the diaphragm and the abdominal wall. We know that there is no blood work and no imaging that is 100% diagnostic for endometriosis. We diagnose endometriosis at the time of surgery. The gold standard is histopathologic confirmation, so that means endometriosis lesions are excised, they are sent over to a pathologist who looks under a microscope and confirms that there are endometrial glands and stroma that are present outside of the uterus. So on laparoscopy, what do we see? So these are all examples of various types of superficial or peritoneal type endometriosis lesions. There are what we consider classic lesions, so this black powder burn type lesion seen on the right-hand side, but there are non-classical or atypical lesions that can be red, white, vesicular, clear, porous. All of those too can be positive for endometriosis on pathology. What else can we see? So on the left-hand side, you see a normal pelvis, so normal ovaries, uterus. On the right-hand side, you see a more advanced case of endometriosis. You see what we consider bilateral endometriomas, kissing ovaries. You can see clearly on the right that the right ovary is enlarged with what is known as an endometrioma or a chocolate cyst, and that the rectum is pulled up as well. After surgery, we often get this question, and it can be an important question in some scenarios. What is my stage? So there are many, many staging systems that are out there. The most common is the system put out by the Reproductive Society back in 1996. Just part of it is seen here on the left-hand side. AAGL, which is a surgical association, just created one back in 2021. All have their limitations. What I think is most pertinent here and what I think is most pertinent for our patients is perhaps not this chart, but just a general sense, a general idea of their stage. So I like to go back to actually something a little bit more basic. I use a staging system for our patients where I say, early stage disease, advanced stage disease, disease involving the ovaries. Stage 1/stage 2 disease is really consisting of minimal disease, superficial disease. Stage 3, 4 is more indicative of that last photo we saw, the kissing ovaries, the destruction of some pelvic anatomy. We even discuss things like stage 5 disease, which are multi-organ disease affecting bladder and bowel and possibly the diaphragm and thorax. I bring up staging here, and for the main reason that many studies have shown us that stages have no correlation to pain. So as Dr. Sajkin likes to say, you cannot stage pain. That brings me here to my central question. Why does endometriosis hurt? So, once we have endometriosis, once an endometriosis lesion is established, it appears to actually cause changes at the site of implantation. So each individual endometriosis lesion has the potential to have these changes happen. You can really sort of divide them up into 3 changes. So 1 would be inflammation, 2 physical damage, and 3 nerve damage. Looking at just inflammation, we know that endometriosis implants themselves cause a local inflammatory reaction. 2, menses. Why do so many of our patients, why is their primary complaint 10 out of 10 pain with their menses? So the menses really are, what happens is a cyclic production, so monthly production of inflammatory cytokines, so inflammation. We know that there's an increased production of these inflammatory markers each month. These markers cause increased pain and can create, almost a toxic environment in the abdomen. The next is something that we call nociceptive pain. So this is that physical pain we talked about. This is pain caused by stimuli that really results in bodily tissue damage. It's physical trauma. It's associated with a number of conditions that do actually also include inflammation, but also things like infection, ischemia. So that's lack of blood flow, or mechanical or compressive injury. So think of that deeply infiltrative endometriosis, think of that advanced stage endometriosis that destroys organs, that dives into organs. Nociceptive pain is usually pain that happens in response to an acute situation. That's how it was designed. So take, for instance, post-surgical pain or pain that results from, say, a sports injury. It was initially a type of pain that is designed to help your body heal. So if you think about spraining your ankle or hurting your ankle, when you step on that ankle, it causes the body pain. So what you do is you take your weight off that ankle and you give that organ, that body part, time to heal. Nociceptive pain is often described as sharp, aching, throbbing. Next, endometriosis can also cause neuropathic pain, so nerve pain. The pelvis contains an extensive plexus of nerves. They have done studies that show that peritoneal fluid, so that's the fluid in the abdomen, the peritoneal fluid of endometriosis patients contains increased nerve growth factors. So you actually have neurogenesis, the creation of new nerves. We can see that the nerve density around endometriosis lesions is increased. Neuropathic pain, patients often describe as burning, shooting, stabbing, tingling, numbness. Interestingly enough, estrogen itself can directly increase proteins related to nerve growth. Most women will not just have one type of pain, they will have a combination of nociceptive and neuropathic pain. So when your pain becomes chronic, so chronic pelvic pain is defined as non-cyclic pain that occurs for 3 to 6 months and is unrelated to pregnancy, more often on the 6-month time frame. Persistence of an acute pain source is a huge risk factor for developing chronic pain. So I often have my patients tell me, when I was younger, I only had pain around my periods. Then after a few years, I had pain a few days before my period, then a few days after. And now I have pain, 7 or 8 days before my period, a week during my period, and a week after. So now I only have 5 to 6 good days a month. And that is a very, very common complaint. That pain becomes progressive. So what's interesting now is endometriosis and then the subsequent developments of chronic pelvic pain can really change the way a person processes pain. So now we've moved beyond the peripheral nervous system into the central nervous system. They did a nice study back in 2012 that looked at the brains of women with endometriosis and chronic pain and saw that certain areas that process pain were inherently different in women with pain and without pain. So you may have heard the idea of this before, the idea of central sensitization. So this is a process happening in the central nervous system. Over time, with repeated stimuli, with chronic pain, patients become more and more sensitive to that peripheral stimuli. At some point, pain can even become independent of that stimulus through mechanisms that are very similar to that of creating a memory. So with central sensitization, there's tissue damage or endometriosis, say an endometriosis lesion that initiates this process of pain, and over time, if it's sustained, it amplifies your pain. This idea may explain why patients have pain. 1, despite adequate surgical management. 2, they have pain that becomes harder and harder to control. 3, they have pain in response to things that shouldn't cause pain, stimuli that shouldn't cause pain. So that's something called allodynia. And they can also have a heightened response to things that are, mild to moderately painful, and that's known as hyperalgesia. I think one of the best examples is the idea of a sunburn, where after a sunburn, just simple touch or pressure can be excruciating. We often get this question as well. Why does my bladder or bowel hurt? Does that mean I have a lesion on my bladder or bowel? Well, yes, maybe, but maybe not. Pain can be described in one of 2 ways. So this is a different way to classify pain, visceral or somatic pain. Visceral pain is pain that comes from internal organs that's particularly susceptible to inflammation, distension, compression. This is pain that is much more vague. It can feel very deep. It can feel like a pressure. It's really hard to localize. Somatic pain is pain from muscles, bones, soft tissue, and that pain tends to be a lot more sharp and intense. What we know that our bodies are very, very poor at processing visceral pain. Which brings us to the idea of referred pain. So that's pain that actually originates from a visceral organ, a viscous like your bowel or your uterus, but it's referred to a somatic organ. the first thing we learn, in medical school, the best example of this is when, someone has a heart attack, it's not typically felt, in the mid-chest, but very commonly felt in the left arm or the upper abdomen. It's another reason while after laparoscopy, where we worked on the abdomen, you will feel pain in the right shoulder. I just want to spend a couple of slides on this. I think, I need to mention that pain is very much related to psychosocial status. Many studies have shown that women with endometriosis have a higher incidence of depression and anxiety, stress, poor and/or declining quality of life. Endometriosis, as we know, can be disabling enough to compromise social relationships and work. There was one study published quite a while ago where they surveyed about 100 women. 80+% showed depressive symptoms, and a similar number showed anxiety. I bring this slide here, I bring this study here because what was again interesting is that these findings were not correlated again with any stage of disease. Interestingly too, these findings were correlated with age, so being worse as time went on. Other studies, these are very high rates. Other studies have reported much lower rates. About 30%, another study showed 30% with moderate to severe anxiety and about 15% with depression. I think bottom line here, we know that endometriosis is associated with some psychopathology. Here too is this very important, graph. What comes first? I think a woman with endometriosis and chronic pain can insert themselves into any part of this cycle. We know that psychologic conditions amplify the perception of pain, and it creates this vicious cycle, making pain and pain psychology worse. I don't want this to be too depressing of a talk, but this is one of my last slides on additional components of pain, but the idea of chronic pelvic pain can create something of a cascade effect. So because you have this, now you have X, Y, and Z condition. So one of the most common sequelae of chronic pelvic pain is something called spastic pelvic floors. So this is likely related to repeated microtrauma of the pelvis, and that finally leads to hyperspasticity or hypertonicity of the muscles. So a few slides here on sort of guiding principles for pain relief. So, we really believe that early diagnosis and treatment is the key. If you remove that initial source of pain or that pain stimulus, you prevent that pain from taking root, or you can prevent that memory from forming. That would be the best way to treat pain early. Other ways also include decreasing sources of estrogen, also decreasing inflammation. Again, the most important here too is multimodal collaborative care. So multimodal, different forms of traditional medication, complementary medication, collaborative, meaning all different types of specialties will all contribute to appropriate care for pain. So treatment option here, these hormonal medical management and surgery are sort of the foundational elements for endometriosis. In terms of hormonal medication, many patients are put on oral contraceptives early. We do know that continuous contraception with the goal for amenorrhea, so no periods, can be effective for some women. If you break that cycle of cyclic inflammation and you can decrease some of that pain, some patients can get pain relief for quite some time. On the other hand, we know that some patients, even despite the best surgery and optimal medical management, will need additional interventions for optimization of pain. So here are some additional medical options. So oftentimes anti-inflammatory medications such as NSAIDs, most commonly over-the-counter Motrin, But naproxen, celecoxib, diclofenac are some examples. All of them have slightly different mechanisms, and some patients may respond better to one rather than the other. There are neuropathic pain medications, so that's pain medication geared towards that shooting, tingling, nerve type pain. There are muscle relaxers, antidepressants, anti-anxiety medications. The ones here, Cymbalta and amitriptyline, are often used in pelvic pain conditions, as they also have, a small neuropathic component, and things like corticosteroids to decrease inflammation. Here are a number of other complementary treatments that many of our patients have tried, and many of which have found benefit for a certain subset of patients. All of these, again, are geared towards decreasing inflammation, and increasing, positivity, and decreasing anxiety. So exercise, diet changes, mindfulness and meditation, something like a TENS unit, acupuncture, pelvic floor physical therapy, CBD and THC products, trigger points, etc. This will be my, one of my last slides, but again, here we are as endometriosis specialists, but we could not appropriately care for our patients without this collaborative care. And I believe most of our patients at one point or another will need a combination of the following specialties to really achieve optimization of pain. And this is by and large not a comprehensive list, but other surgical specialists, a psychologist, a psychiatrist, a pain specialist, a nutritionist, and of course their family and social support. Okay, these are my references, and thank you so much for the opportunity.
Hello, my name is Melissa Boudreau, and today I am going to talk about endo strategies for managing deep disease, but a little bit of background about myself. I am an endo warrior, and I have had 7 surgeries for endometriosis, and I've been suffering with the disease for about 29 years total. It took me 11 years to get my first diagnosis, and I started just suffering in pain at a young age, and from there I just was on a discovery of trying to figure out what was going on with me. And in my mid-20s, I was finally diagnosed with endometriosis. I have deep infiltrating endometriosis, and 4 of my surgeries have fortunately have been excision surgeries, and the other surgeries were not, but that was before I knew what surgeries helped to treat endo. So in thinking about this topic and title, and what I wanted to share is endometriosis is something that we all as sufferers have lived with on a daily basis. And as time has gone on, and it's 29 years and I still feel like I'm figuring things out and learning things on a daily basis, I started to discover strategies and things that helped to at least make day-to-day life easier, better, and help me manage a little bit more of the disease. As we know, there's no cure. So I started to change my lifestyle as time went on, and each year I felt like I was learning something new and learning something different. In the very, very beginning, when I was still in my young 20s, I found that caffeine, gluten were really affecting me. And I did this by tracking. So get a journal out and track what you're eating and track what you're drinking. I was the person who was getting, the largest coffee that you can get every single day. I worked a retail job, so I was on the go all the time. And I cut caffeine out first, and it did help. It was very challenging in the beginning to cut caffeine out. And I switched just to drinking decaf, which I know still has a little bit of caffeine in it, but that was one of my first strategies. And then I cut gluten out next. And I learned that just from other people in the endo community that said it had helped them. At the time, again, a lot of people were not knowing about cutting out gluten. I had a friend who was celiac. Actually, she was my roommate, which is very convenient because she didn't eat gluten. So I really started to learn what foods I could eat, what I couldn't eat. And she was very helpful in that, even though, obviously we had different things going on. That really, really, and it's different for everyone. So these aren't, I'm not saying you have to do these things, but providing strategies to help manage your day-to-day pain is something that I'm really passionate about, because it took me a long time, and I still struggle with pain. But it took me a long time to find the things that worked for me. But going back to gluten, that was a huge change for me. I was still in a lot of pain on the daily basis, and I was still in a lot of pain with my cycle, but I really did notice a difference, and it made it very easy for me to just completely cut it out 100%. And there were times I didn't know, like Twizzlers have gluten in them. I'm sure most people don't know that. And I remember being like at a movie theater eating them. I didn't feel good afterwards. I was like, oh, it was probably too much sugar. Well, they had gluten in them. So then I could just immediately tell if I had accidentally eaten it in something that I didn't know, soy sauce, things like that I didn't know gluten had or was an ingredient. And my stomach would get very, very swollen and bloated. So those were the first two things diet-wise and strategy-wise that I really cut out, not knowing still at that point what my journey was going to look like with this lifelong disease. So diet was one of my main strategies. And then as time has gone on, I've really hyper reduced alcohol. In my 20s, that was very hard when I was going down this like initial path of being very sick, but I was so sick that it was really hard for me to continue to drink anyway. So alcohol was another thing I cut out, and then eventually sugar, which I still, not gonna lie, still have here and there. But for me personally, those things really helped. And I know we talk about endo diet and things like that. I think it's different for everyone. So it's really about testing it, writing it down, figuring out what works best for you. Now, kale sometimes bothers me. So it's not just the foods that are like the bad foods. It's just depends on who you are and how you digest and how your body works. The other strategy that I've worked for helping to manage disease is I've really slowed down in my life. I was this person who was on a go, 24/7, working, traveling, doing all of these things. And I really realized how much that was affecting me. I was never taking the time for myself. I was never taking the time to rest. I just pushed and felt like I had to push to get everything done, to stay at the top of my game, do all of those things. So slowing down has been a huge tool for me. And in recent years, I would start to meditate, then I wouldn't, then I would, then I wouldn't. And I would just get on this roller coaster of trying to do it and struggling to do it because it's really challenging to do. I have luckily incorporated it into my daily life. So every night before I go to bed, just some deep breathing. You can listen to music. It doesn't have to be, sitting there with your hands on your knees, just taking some time to take some really, really deep breaths and increasing that time as time goes on. So start with 5 minutes, 2 minutes, 5 minutes, 10 minutes. Those strategies have really helped in my breathing and calming my nervous system. And yoga has been a part of that too. I don't do that as much anymore, but it did help me learn how to take deep breaths, which helped to calm my pain and my nervous system. So I know these are not like the newest strategies and people talk about these very often, but as someone who's really struggled with deep infiltrating endo and been on this 29-year kind of journey of pain, these things have really made a difference in my life. So meditation, diet, walking is something that I love to do. So even if it's a really rough day, then I won't. But walk around your house, walk around the block, just get out, get some fresh air. That also has been, I was someone who loved to do cardio and in this crazy lifestyle that I was talking about. And I really slowed down and I was like, I just enjoy being outside and walking. And it helps with my pain on the days that I feel really stiff or pain in my hip or down my leg or sciatic pain. Going for a little walk has helped. So that's something I love to do. Gratitude. So I focus on writing 3 things that I'm grateful for a day. And I know that this is a strategy that a lot of people use in their life. but it's really helped to shift my perspective on the really hard days. I look at all I have instead of all of the things that I'm going through or all of the pain I'm in or how hard it is and challenging it is to have endometriosis. And I look at all of the things that I'm very fortunate to have. I know that this is very challenging on the hard days, and I'm not saying I do this every day, and I have the days where it's very hard to be grateful, but it's really helped to shift my perspective in looking at all I do have instead of all that I'm going through or all that's challenging. So writing 3 things down a day, or even if I'm in a state of anxiety or something challenging is going on, I try to think to myself about how grateful I am that I have shelter and food and water and people that love me at a very high level. And you can even get to a very granular level of, I'm so excited that I'm here breathing today. So gratitude's really helped. And then being prepared, right? Always having what I like to call an endo kit on you, something for your stomach, any type of tools that you may need, a small heating pad, those portable ones. I like to have a little zipped pack that's always with me in my purse or in my bag or when I'm traveling, that has everything, ginger chews, anything that I may need that helps me. I always have ginger tea on me, that if I'm out and about and I'm having a moment that I can take it and use it. For example, I was traveling this week with someone else who has endometriosis, and I had papaya enzymes. She was struggling after she ate something, and I gave them to her. They helped digest, and that really helped her. So being prepared. And then strength training is something else. I never thought that I would be someone who lifted weights and did deadlifts and back squats and all of these crazy things that I see other people do in the gym that I would never do. But it's really helped with my mental and physical health. Even if you're doing 2 pounds or 4 pounds or 6 pounds in the weights, it's helped my physical health I'm stronger, helped with a lot of my nerve pain, but it also helps my mental health because I am impressed with how strong that I am. And on a daily basis, when I go to the gym, and I don't go to the gym on a daily basis, but on a daily basis, when I can lift something or I can lift a 20-pound weight, I'm very just excited for how hard I worked to get there. So strength training has definitely been a huge component in my day-to-day life with this disease. And then lastly, making small goals daily. And if you hit them, great. And if you don't, that's great too. I used to be this person that would have a to-do list that would have 30 things on it. And if I didn't get them done, I would be so disappointed in myself. And why didn't you get this all done? And just very hard on myself. I had to take a step back and remind myself, like, I have a chronic condition. It's okay if I don't get all of these things done and I lay down and read a book or lay down and take a nap or I rest with my heating pad. So now I try to only have 5 things that are on my to-do list a day. I mean, I may have 20 things to do that day, but 5 that I have to get done. And that's really helped to shift my pressure on myself, which I think causes more stress, which causes inflammation and doesn't help me rest as much. So resting is one of the main strategies that has really changed how I feel on a day-to-day basis, taking care of myself and putting myself first. So my advice to you is maybe try some of these strategies, try one here, try one there. But really the biggest piece of advice I have is slowing down, loving yourself, taking care of yourself first, and being selfish, which was something that was very challenging for me, is the number one strategy that's helped me feel better. Taking time for myself and really sticking up for myself and saying, I can't, or I'm not able to do that right now. Friends, family, all of that. So I hope that these strategies help. If you want to check out, I have a podcast called The Cycle Podcast. We talk about things all the time. It's mainly where I interview people with endo and they chat about strategies that have worked for them. So please check it out if you'd like. Otherwise, I hope this chat was helpful for you. I hope you're feeling okay today. And thank you so much for listening.
But we have about 15 minutes or so to take some questions that have been rolling in from our audience. So if our panelists are all ready to answer some questions, I will hit you with our first one. First off, somebody is asking about what's the correct definition of endometriosis? We currently have a lot of different ways that we're sort of defining it, but can we confirm if endometriotic tissue contains stroma and glands, and is that required for the diagnosis of endometriosis?
Yes, I'd add to that. It's stroma, it's glands and stroma. Stroma is hard to define, but it's connective tissue. But the glands are distinctive. But I'd add that it's glands and stroma surrounded by fibromuscular tissue. There's always a fibromuscular component with endometriosis.
I think that is true, and I think the most important component of the disease is the fibrosis portion, where it pulls tissues together, causes dysfunction of the organs, and traps nerves. I think this is a great question because there are two things.
Makes it visible.
Yeah, there are two important philosophical from the foundation aspect I want to comment also to previous presentation. One is the concept of peritoneal endometriosis. There's a tendency of calling it superficial endometriosis. I deplore this term because you can't call it superficial. Its peritoneum is an organ and it is in command of the all vagus innervation of the all organs. It has nerves in it. It's a true layer that endometriosis starts, and I think calling it superficial, making it look like it's one of the reasons that many patients are not believed, and most prevalent type of endometriosis is that. For that purpose, we cannot belittle peritoneal endometriosis calling it superficial, number one. The second is we have to remember that the treatment of endometriosis versus management is something we're adamant about in our foundation philosophy. Management, all those things about medical options and stuff, they are not treatment. They are management of the symptoms of the endometriosis. They're not getting rid of a already implanted lesion. As you see, many of these patients that with advanced had 20 years of birth control pills taken. So I think I like to emphasize that. Just so for the record, I want to clarify that. Thank you.
Anyone else with any comments about the diagnosis of endometriosis?
Well, diagnosis of endometriosis, presumptively, clinically experienced endometriosis person asks certain questions very clearly to the patient. And there are 20 questions, not much, but they are like detective, they lead you to it. Most of the important thing is, are symptoms of other organs, whether it is bowel, urination, or pain, this chest, whatever, are they flaring up with the periods first? And the history, how it started. If they're flaring up with the periods and they're on the ground, I mean, you don't have to be asking too many questions. With the exam, right, we all emphasize the exam. The cervix is tender, rectovaginal septum is tender. When you put sonogram probe, they jump on certain location. Pain could be unilateral. In many cases, it's very specific, rectovaginal exam. So before surgery, you presumptively make over 90% of the time, you know that there is endo. To what degree? We don't know in many cases. Thank God it's not very advanced cases that we see here. So, but definitive diagnosis is not even the surgeon seeing the lesion. Probably the best is to take the tissues as individual lesion as possible, subject to tissue diagnosis, or it's like second opinion, and it validates the patient's symptoms that they suffered over years, and it is the definitive diagnosis. Every year we see some borderline cancer. Every year there is some carcinoid, like adrenal gland tumor, or that kind of endocrine tumor. Every year they see some weird lymphoid hyperplasia there. It looks exactly like endo by appearance. It's fair to make the correct diagnosis in sake of medicine. That's all there is to it, I have to say.
Amer, if I can say,
Please.
Most important thing is early diagnosis. God damn it, before it starts growing.
Exactly.
Yes.
And most of the time, the patient is told, take this, take that, and there is no follow-up and there is no early diagnosis.
Along those lines, do any of you foresee us being able to use like a biomarker or imaging rather than requiring a surgery for diagnosis in the near or distant future?
Well, there is no biomarker or imaging in the vast majority of the cases, the way it starts.
But
it's that magic question.
Laparoscopy is a very simple procedure today. And you can even do it with a very small scopes.
Yeah, 3 millimeter scopes, yeah.
Pelvic exam has very little application to endometriosis. If they don't do a rectovaginal exam, forget it.
Yeah, but rectovaginal exam will demonstrate endometriosis. We always, in my department, suggested to do rectovaginal examination. This is very important, but you can only detect a certain area.
And also young women, young girls, it's so difficult to do it. I mean, they don't accept it. They come with their parents and stuff. There is a line. It's each patient is different. You have to make sure the patient understand and willing to do it. You just can't do it. It's not easy. So in the end, laparoscopy becomes the mainstay. It's just the education of the parents and the patient and their awareness level plays the most important thing, I think. Thank you.
Tamir, it's a rectovaginal disease. Very rarely is the rectum avoided if it's on the vagina.
I just want to say it's difficult on certain patients that they don't want to accept that, for many reasons. It's sometimes they're transgender, they have other issues with their sexual area. Yeah, this is New York City, this is modern times. It is, we were not aware of generation X, Y, Z much, but times have changed. It's true.
X, Y, Z, eh?
X, Y, Z. we are the generation history. They are X, Y, Z, yeah.
Yeah.
So you all are advocating for excisional surgical techniques. I think that that's pretty well accepted amongst this panel. But why are we still seeing so many physicians doing kind of burning and doing ablative surgery rather than excisional?
That's another question, right, from the crowd?
Because they don't know how to do it.
Because of the money and time.
So there's a tendency.
Excising takes time.
Well, there is also a tendency that anybody who can do laparoscopy is right now is endometriosis specialist, or doing laparoscopy is not endometriosis surgery. To see the lesions is not endometriosis surgery. Removing is endometriosis surgery, and complete removal is challenging because the lesions are not typically black, red. Most of the lesions, 75, they're like Harry was saying, everyone is saying, experienced endometriosis surgery, all in the crowd. It's white, it's off pigmented colors. So you have to recognize the peritoneal disturbance of the peritoneal surface and recognize the contraction of the fibrosis. It pulls tissue. You have to know very good anatomy. And even with this superficial endometriosis, they say peritoneal, and every peritoneal endometriosis have little bit of deep components somewhere. The challenge is to recognize that. So that's why these meetings are important.
If you don't have that, Tamir, it could be that your own body's macrophages will absorb it. If there's no fibrosis or no inflammation, I'd have a hard time calling it endometriosis.
Okay. More questions coming?
Yeah, so speaking of kind of surgical approach, how do you guys determine what's the best, especially for more extensive cases? The question from the audience is about robotic surgery versus a traditional approach.
Yeah, if I can say something about that, really, as I'd go back to evidence again, and Harry already emphasized that with traditional laparoscopic surgery, there is a distinct tactile feel. But if you look at the evidence of whether the robot adds anything to laparoscopic surgery, there basically is none. I've told you the difficulties of doing a trial about hysterectomies. I would hate to have to manage a trial comparing laparoscopic and laparoscopic and robotic surgery. It's so difficult. I've looked out the trials that people have tried, and the only one I could find that was anywhere near a reasonable randomized trial actually had operating time as the endpoint. Now, of all the things that a patient is interested in, actually how long they're operated on is the least. And there's a big meta-analysis which shows no difference in any patient-related outcome. There are some obvious differences in costs, and that's the only thing that's really positive, well, really definite about laparoscopic against robotic, is that robotic costs more. So if you even at the simplest level, the fact of something costing more without any perceived benefit is really difficult to justify, except I suppose if people find laparoscopic surgery more difficult and therefore the robot is easier to achieve the same result. But that means the patient or their insurance company is paying for the surgeon not to be quite as competent as they might be. So I would think that the evidence of laparoscopic being better than open surgery is clear for a whole variety of reasons, but particularly endometriosis, because of the difficulties of visualizing. It's quite, you can feel endometriosis at open surgery, but it's pretty difficult to see deep down and in the various corners they get. So clearly, in most cases, laparoscopic is going to be preferred to open surgery, but laparoscopic is, I think, at least as good as open surgery in anything you can measure other than the cost of the procedure and maybe the operating time.
Hey, and it's the surgeon that operates. You know, that is the most important factor. The surgeon itself.
I've heard the argument that robotic surgery may improve access to surgery. I'm wondering if any of you agree with that.
Look, and I think the most, many more such comparisons have been done with prostatic surgery. And at the end, the result is it's the same.
But one thing is true: the incision size is double to triple
with a robot than conventional size.
My take on robotic surgery, to be honest with you, even though I had privileges of doing the just when it started, 2005, in my hospital, I got the first. Truthfully, I could not, in my best of my conscience, and my heart did not go for it, because I declared it as a maximally invasive laparoscopic surgery. I mean, so you end up with maximally invasive laparoscopy. So you end up with 5 trocars. At that time, they were all 2 centimeters each. I mean, if you add them up, you rather do a laparotomy. I mean, whereas you can achieve the same thing is 3-5 millimeter instruments, or at most, when you add the incisions, it becomes not more than 2 centimeters. The way we've been doing like 20 years like that, and the other guy comes, here is your robot, now you're going to do this. The problem is the concept of robot is so sexy, it fits to our generation. All the hospitals bought, they did not buy these, they leased them. So if they don't use it, they lose money. I hate to say that, but there's pressure also from the hospital system for their hospitals to use it. It takes longer time. We still do some, with fibroids and stuff, not for endo. I don't use them at all, but fibroids for other things, for simple hysterectomies, we may use it, but it takes more time. It's more expensive. There's more trocars. Otherwise it's okay. That's all, but these are the facts.
I've got one more question here before we run out of time, and I'm consolidating a couple because some audience members have questions about endometriosis causing nerve pain, and specifically sciatic and vagus nerve dysfunction. And I'm wondering if you guys want to comment on your experience with the nerve pain from endometriosis.
I mean, first of all, it is I think the next conference could be on vagus nerve for dummies, because it is it is the whole gut system is under the dominance of the cranial nerve 10. That's vagus system. That is something that we don't control from our breathing, from our heart rate, from all the gut feeling of distension, gas, bowel movements are all part. Of course, there's some voluntary things that helps this, but the whole thing is about peritoneum. Peritoneum and mesentery has been declared by Gray's Anatomy just recently, 2 years ago, as another organ, because it really monitors the whole body's digestive plus fluid traffic through the abdomen, whether it's blood vessels, whether it's thoracic cavity. It's a magnificent, pristine organ, peritoneum. In that sense, everything that you feel about vagus nerve, because it's got sympathetic and parasympathetic, autonomic and muscular dominance without your control is what you really feel. Coming to sciatic, luckily, as much as more sciatic complaints, that means the butt pain radiating from the back of the leg, mostly unilateral. Many times in those patients, you don't find sciatic nerve involvement at all, 90% of more than that. However, it's all referred pain between promontory and the ureter course that exchange on the hypogastric nerve trunk all the way down to the ureterosacral ligaments. They usually cause referred pain to sciatic pudendal area, and you can't really treat this unless you know how to go retroperitoneal and follow the disease. Disease will basically lead you to those areas. Rarely you never have a normal peritoneum and then suddenly one sciatic lesion. Rarely. You may have it, but not necessarily.
Tamir, next Sunday, next week, you're going to have the world expert.
Exactly. Dr. Posover will be with us again. He's going to talk about sciatic endometriosis. Yeah, it will be nice to see you again, guys, next week. It will be very exciting.
And that's a great segue for us to kind of bring today's session to a close and plug next week's medical conference. So thank you all for joining us today.
Thank you.